Well, welcome everybody to the public session of NHS England and NHS Improvement. I've got apologies from Dido and Ara. And first I should just say that this is Noel's last board meeting. And Noel, just on behalf of us all, thank you very much for the huge contribution you've made to the NHS over many years, and also for the time you spent at NHS Digital as well, which has been hugely appreciated by all of us.
Thank you, David.
Thanks, Noel. And secondly, just to congratulate Tim on behalf of everybody again for your appointment, Tim, as the National Director for Transformation beginning in May. Any declarations of interest that haven't already been declared? Can I approve the minutes of the last board meetings? Good. So Simon, over to you for the Chief Executive's update.
Okay, thank you very much, David, and afternoon, colleagues. Firstly, can I note the sad death of Dr. Cliff Mann, who was our National Clinical Director for Urgent and Emergency Care. And Cliff was a great friend and a source of wise advice to the whole of the NHS, as well as remaining very closely grounded in the realities of day-to-day emergency medicine. So I think we have taken the opportunity to mark the contribution that Cliff has made and say to his family how sorry we are at his loss. If I could also add my thanks to Noel Gordon, as you have done, David, for Noel's fantastic non-executive leadership on the NHS England board, right back to 2014 in a variety of capacities and other NHS service as well. And then to set the scene or set the table for our public meeting this afternoon, 3 points really just to get us kicked off. Firstly, in terms of the current position in respect of COVID and the pressures in the NHS, I'm pleased to say that the inpatient numbers continue to come down very sharply. You'll remember that we had over 34,000 severely ill coronavirus patients in our hospitals in mid-January. That number is now 4,000. And although that is still about 400 more COVID patients than we had this same day a year ago, nevertheless, that very sharp decrease in the number of patients with COVID in hospital is a consequence of both declining infection rates across the community and the impact that's now being felt from the vaccination programme. And as a result of those much reduced acute pressures on the health service, today I'm recommending that we reduce the national alert level across the health service, the EPRR alert level, from level 4 to level 3, and that would take effect today. And as I say, that is partly as a consequence of the second huge field of activity that we've been involved in since our last public board meeting, which is the continuing rollout of the vaccination programme. Since our last public meeting on the 28th of January, we have administered 19.5 million COVID vaccinations across England, and within the next 24 hours or so, we will pass the 25 million mark, 25 million people across England who've had at least their first jab. We are, as we'll hear from Emily Lawson in a moment, completing the job for the first 9 high-risk groups, people aged 50 and above and other high-risk individuals. And we have, for the latest age group that we've been targeting, the 50 to 54-year-olds, gone from a position where about 2/5 of those people in their early 50s had had their vaccination at the start of last week, to a position where in the next 24 hours or so, we should be at 3/4 of people having had their jabs. And that, I might add, includes me. I was very grateful to be vaccinated last week, along with millions of others of my age group. And so we are now particularly gearing up, as we'll hear from Emily, for second doses, with April being a particular focus on second doses. 2 million people across England have already had their second COVID vaccination. And yesterday, over 40% of the vaccinations that were given out across England were second doses. So given the decreasing COVID pressures, given the accelerating COVID vaccination, the third thing to set the scene is that today we set out the operating rhythm for the NHS for the year ahead, for financial year 2021-22, which begins on the 1st of April. And there's been a lot of work across our entire organisation, some of it behind the scenes, working with the NHS, with our partners in patients groups, and with government to get this right. Today, the government have published the mandate for the National Health Service for the year ahead, and matching that this afternoon, we are discussing and approving the operating planning guidance for the health service for the year ahead. We've got funding certainty for our COVID costs for the first half of the year, which I personally felt was very important that we had that planning certainty. We've got extra funding that we'll be deploying to tackle long waiting lists. We are doubling down on the investment guarantees that we have made for mental health services and GP and community services. And as we'll hear later on this afternoon, additional investment for maternity services as well. And within the last week, we have formally approved every part of the country to be designated as integrated care systems, showing the benefit that joined up working has brought over the course of the last year. So David, those I think are the three scene setters for our discussions this afternoon on COVID, on vaccinations, and on the year ahead.
Thanks very much, Simon. That's very clear. Anyone like to kick it off? Ara, you've got views, very strong views on vaccines, and you've been involved with the NHS for many, many years now. Where do you see the biggest challenges as far as going forward?
Well, I think, firstly, we have to acknowledge the amazing work that the NHS England has done in getting the vaccines out. And thanks to Emily and the great team that Simon leads on. It's really the pride of what we've done in terms of seeing the end of this. I mean, the vaccine, we were not just good enough in the implementation, the whole pathway, the procurement of it, the decision making, and obviously the jabs. Achieving 850,000 in one day. That's a global record in terms of per capita. That's a phenomenal achievement. Where are we going with the vaccine? I think obviously there will be the cohort who needs to get their second jab. I think we're moving in the different categories, as we all know. It's all in the public domain. I think the next is, how do we use the vaccine? And I was at a meeting this morning to see what type of a certification we need in terms of, an individual citizen could free up and to go back to work and start businesses and contribute to the economy. Obviously, with the constraints still that we need to be careful now to get the balance right between the security of the vaccine, but at the same time that we don't lose some of the interventions that we put in place, like social distancing and wearing masks. And I mean, from a vaccine perspective, there are two elements from it. Vaccine protects the individual, but at the same time, we need to ensure that individual is not transmitting virus to others. So that still remains a gap in science, which we're looking at the moment. There are obviously how we integrate COVID vaccinations as part of our annual flu vaccines in the future, but all positive, something that this nation should be very proud of, and the taxpayers should be very proud of the NHS. Remarkable job, really.
Thanks, Ara. And Laura, I'm looking at Laura Wake-Geary in terms of the digital changes that have happened over the last year. I mean, it's been an extraordinary change, I think, over the last 12 months.
Yes. So thank you, David. Indeed. I think that the progress that the NHS has made in moving to digital services has taken, I think, almost the service itself by surprise in terms of the change that has been possible and the extent that that has actually enabled normal service to continue. So whether that's the rollout of Attend Anywhere to enable outpatients, or indeed much more use of online triage with GPs. I think it's been an amazing year that we now have the opportunity to build on as we go into the work that we'll talk about today in terms of the recovery programme and increasingly putting digital at the heart of all of our activity. So I'd like to kind of congratulate, I think, the teams in NHS Digital and NHSX as well as E for kind of the leadership they've shown, but actually everybody at the front line for how much they have adopted and kind of taken forward what's been made available or they have found.
Thanks, Laura. And Andrew Morris, I mean, you've been in the NHS for 40 years and you've seen it through good times and bad times, or tough times and less tough times, or maybe all the times are pretty tough. I mean, how do you characterise today's challenges compared to what you've seen in the past?
So I think the last 12 months have been the toughest of the tough. Going forward, getting the backlog on the waiting list down is going to be the one priority, but we've got to look after our staff first and foremost. They've gone through a really challenging time. So I think all the efforts that people have made, we've got to recognise, and I think employers, trusts that is, have got to do all the general kind of housekeeping bits, making sure that people take the leave that's due, looking after the health and well-being of their staff, and giving people an opportunity to just spend time with their family and not focus on the NHS for once. However, we've still got the big job of bringing waiting times down, which will be probably the biggest challenge for the next 2 years. And everyone needs to be, focused on that. And I'm sure clinicians want to get back to working in a routine way that they've done before. I think there are some fantastic opportunities around transformation, doing things differently, and using the ICSs, the integrated care systems, as a way of improving pathways and taking steps out of pathways so we get a faster, slicker service to all.
Thanks, Andrew. And David Behan, just on the workforce point that Andrew raised there, I mean, in a sense, one can never do enough for the people who've done so much over the last 12 months. But what's your perceptions of where the workforce are at the moment?
So just to reflect comments that colleagues have made about the emotional and psychological and physical demands that have been made on staff. But I think to Simon's introduction, looking to the future, I think the planning guidance for this year is really clear on the importance of supporting staff, and we need to do that in the short term. Investing in our staff is one way to ensure that the point that Andrew's just made about working on the backlog and doing that quickly is going to be secured. One of the things that's impressed me, though, about staff during the past 12 months, David, has been their agility, their ability to work flexibly, the ability to work in teams, and I think that's a fantastic reflection on staff. And it's important we secure some of those changes as we look to the future and go forward. From an education and training point of view, it's absolutely critical we begin to secure a pipeline of people coming through. The brilliant news is that the past 12 months has served as a real advert for health and care professionals, and applications to university for both nursing and medicine degrees are up quite significantly. They were up last year and they're up again in terms of applications to university this year, which is a fantastic development. And I think that can begin to give us some confidence that we can secure the future workforce. But we do need a long-term, multi-year settlement for the workforce, because we need to plan this over the long term and think not just about 21, 22, but the next 10 years or so, where we can actually lock in some of the changes, the transformational changes that we've seen. And I think, to Laura's point, digital is going to be a key enabler to that. So investing in the workforce and then investing digitally is key to the future. But tremendous achievements over the past 12 months, and the planning guidance, I think, gives some real clarity on what the next steps are for the system. Thank you.
Thanks, David. So, Simon, I mean, if you think back to before the coming together of NHSE and NHS England and NHS Pre-Improvement, I think we now have a sort of a unified team at the centre, which I think has made a huge difference. And so I think from all the non-exec directors of NHS England and NHS Improvement, a huge thank you to the executive team who have put in so much time and energy and intellect into this over the last 12 months. So thank you very much for that, to the whole team. So shall we move on to Emily then, Simon, or did you have anything else you wanted to raise, or should we go on to the vaccine deployment programme?
Yep, let's go on to Emily. Yep.
Okay, Emily.
Thank you, Chair. So I thought I'd give just a few words of introduction, given that we've already discussed some of the aspects of the vaccination programme, and the paper is presented for the board to note. So the news, as discussed, is that the vaccine deployment programme continues to go well. So we met our mid-February target of offering to cohorts 1 to 4, and we are on track to meet the target for mid-April of offering to cohorts 1 to 9. Indeed, all of cohorts 1 to 9 currently have the option of being vaccinated, and we're seeing tremendous uptake, as the board has already noted, particularly last week, where over 3 million vaccinations were delivered in week for the first time, and second and first doses being delivered at reasonable scale in the same week, with a step up in second doses already this week as we track over the week of the 4th of January, where 1.5 million vaccines were delivered in the first place. So those second doses will track up, and April will be, as Simon mentioned, second dose month, with over 2.5 million second doses being delivered in most of those weeks. So we've made significant progress on that delivery of first doses, and now need to make sure we complete people's vaccinations with the second doses. The vaccinations being delivered through primary care. GPs have received their notifications of second dose deliveries and when they will come through to sort of second half of April, and we'll get those through to the end of May shortly, or the middle of May shortly, so that they can book appointments accordingly. And listening to feedback from sites, trying to stick to single days for single sites so that they know what's coming and when, and can book appointments, particularly for second doses, far enough ahead to give everybody confidence in that process. For the next few weeks, there will be a limited number of first doses delivered. So we will be working really closely with sites, local systems and regions to make sure that those are routed to communities and systems which have lower uptake in cohorts 1 to 9, to ensure that everyone in cohorts 1 to 9 has both received an offer of a vaccine and an opportunity to take it up. Efforts on uptake have been a core part of the team's activity over the last over the whole period, but particularly over the last sort of 8 to 9 weeks, as we've got better data on uptake and where uptake is going faster than in other places. Critically following the World Health Organization's guidance on what it takes to achieve outstanding uptake and to ensure everybody feels comfortable to come forward to receive their vaccine. This is, as far as possible, community-led. We've provided funding via CCGs to work with local communities to identify ways in which additional sites, for example, pop-up sites, can help people feel comfortable to come forward and access the vaccine when the offer is made to them. And we're continuing to innovate, working with local communities. And we've started to see the real impact of that by tracking those who come forward and the penetration of vaccine uptake in particular communities. So if I give you one example, those who are who've identified their ethnicity as either Asian or Asian British with a Bangladeshi origin, where there's been efforts led by Bangladeshi community leaders, by imams, and by local communities, including Naeem Ahmed from the People team. We saw a change in the uptake of the vaccine within all of cohorts 1 to 9. Between the 1st of February, where 15% of that group had the vaccine, bearing in mind, of course, that not everybody in 1 to 9 had been offered the chance to have the vaccine at that point, to over 75% yesterday. So a real acceleration of uptake in a group where we've identified what particularly works for that community, what sites work, the use of pop-ups, religious and other community leaders to help increase confidence, decrease complacency in the vaccine, and make sure people feel comfortable accepting their offer. So the work for the next few weeks will obviously focus on outstanding operational delivery every day to give people confidence that they'll receive their second dose, that the vaccine, that they should take up their offer of the vaccine when it's available to them, make sure sites have what they need to deliver every day, and to continue to work with communities to make sure we're innovating and working with local groups to make sure everybody feels confident having the vaccine when it's their turn. Over.
Do put your hands up if anyone wants to raise any questions from the board. But Emily, looking at the programme through the lens of health inequalities, an issue that WAL has raised a number of times in the past. I mean, you gave a particular example, but overall, are you so not happy with it? Are you pleased with the degree of uptake from, particularly from Black and minority ethnic communities?
I think you chose your words carefully, David. If I can give the sort of dimensions of that the uptake from Black and minority ethnic groups of the vaccine is way in advance of any other public health campaign of the last several years. And, in some groups, for example, it is double the uptake for flu. So there's been something about the pandemic that's really managed to catalyze that sense of personal and collective responsibility. And what we've had with the transparency of data that we've got is the ability to track daily the uptake, both at a national level, but also locally, and therefore work with local communities to understand what's getting in the way, right? To take access out of the equation, to work with local leaders to address confidence, to make sure messages are being shared by those who are trusted to deliver the message, and also to use this as an opportunity to increase access to healthcare more broadly. So we have several initiatives, for example, of running, this doesn't address the Black and minority ethnic group, but a group that also doesn't access all healthcare services in at equal levels to those living in different environments. So the homeless community, for example, local sites have run integrated health clinics offering dentistry, ophthalmology and vaccination at the same time, and encouraging people to register with a GP who haven't previously been registered. So I think the program's given us, through the example I cited earlier in that example, the opportunity to increase a level of trust and connection with the health service more broadly. So while the uptake in Black and minority ethnic groups doesn't track in every part of the country the same level as white British uptake, for example, there is also an intersectionality aspect in that those cohorts with the highest levels of deprivation have not come forward in as high numbers as those in the least deprived. While those numbers aren't the same, I'm not happy. But I think we have to recognise that this has already this has in many ways, in terms of uptake, gone incredibly well. We won't rest until every community feels that they've been involved in that opportunity to come forward, that we've answered any concerns and questions, not we necessarily, but the trusted leaders, clinical leaders, religious leaders have answered and been able to have conversations about the concerns that people have. And we see every day, every week, that penetration and that uptake ticking up gradually. And as I said, I picked the Bangladeshi community example because that showed such a steep increase in uptake when we had the right combination of working with local leaders, of pop-up clinics and of the right messaging. So we need to find what is that right combination for all communities. and the level of ownership by individual communities is tremendous. So we just need to make sure we keep that up, and we keep making sure everybody's aware that the offer is made at a certain point in time, but it's open forever, right? If you come forward now and you're in cohort 2 and didn't take up the offer at the time, we will find you a vaccination. And it's really important that I hope everybody hears that message, and everybody who isn't confident knows, they can have a conversation. We'll provide the right materials, the right people, the right environment, I hope, to deal with any concerns that people have.
Thanks, Emily. So, Wal, then Ian.
Thanks, David, and Emily. Thanks for outlining your efforts in this area, which seem to be going well. I think, though, that there's, as ever, the challenge continues, and I know you're not complacent, even remotely. As we move out of cohorts 1 to 9, the things that worked back in you've tried so far may not work quite so well as you move down the age group. So, and I know you're on it, but I just want to really be absolutely doubly sure that you're totally on it. The combination of different things, the local leaders, religious leaders, may not work quite so well in this next phase. And just making sure we're innovating and being agile in the way we're approaching this is really, really important. That's the first question. Second question is around some of the things you're not in control of, Emily, and this may be something that some of our clinical colleagues here, I'm looking particularly at Munir, might want to get involved in, that the news flow around some of the vaccines is not great across the water for a range of reasons, and that's both across in Europe and in America. I'm just wondering what we can do to just, again, reassure people, and again, the further down the age cohort you're going, the more this become a factor, reassure people that, the vaccines are safe and it's worth taking and they do work. Thank you.
Emily, could you reply to that now, do you think?
Yes, of course. So, I think on the innovation and creativity point, the point is well taken, and one of the reasons for giving the local funding was to encourage that innovation at a local level where people have a really good understanding of what's missing and what could be done to improve it. We are doing the work both for the move into cohorts 10, 11 and 12, when we which will we'll receive, I hope, guidance from JCVI over the next couple of weeks that about how to think about that prioritisation. And we have, campaigns planned and that kind of thing to increase vaccine uptake among younger groups, which obviously, we're not pushing out at the moment because April is going to be second dose month, and that push into younger cohorts will happen later in the spring. But I completely take your point. We need to continue to use the insights that we get every day from the data to refocus our efforts and to make sure we're thinking about meeting people where they are, right? So rather than this being convenient for us, what's convenient for the people who are receiving the vaccine, what's inspiring for them. And what I've seen as I've been out to visit sites and local systems is tons of innovation. So we need to support people in doing that, and then obviously provide the national infrastructure to scale that, steal it, publicise it, make sure everybody knows they've got permission to extend these offers in innovative ways, so long as that's safe and within the existing clinical guidance. On the news flow, shall I hand that to one of our clinical colleagues, David?
Munir or Steve, would you like to comment? Or Ara?
I can comment. So the sort of risk benefit is critical with any intervention such as a vaccine, and this is being intensively monitored throughout the world. The MHRA has been looking at this every day in terms of reports coming in, plus also the effectiveness, working with partners such as Public Health England and the NHS to make sure that the benefit risk is positive. The EMA came out last week and said that the benefit risk is very positive and the vaccine is safe and effective, and the FDA has done the same as well. And overall, there is a huge amount of work going on to continuously monitor the effectiveness and safety of the vaccine.
I can concur with that. Obviously, as with any vaccine or drug, the two key things to look at are effectiveness and, of course, safety is always paramount. Vaccines in general are highly effective interventions, health interventions, and are also extremely safe. We know that from many years of experience, and there's no doubt these vaccines are effective. That's not only been shown in the clinical trials that the various vaccines have gone through and are continuing to go through, but also in the real world experience. Here in the UK, we are seeing data from Public Health England, but other academic bodies too, showing not just a reduction in infection rates, but very importantly, a reduction in hospital admissions, and I'm sure that will be translated into deaths too. And of course, in other countries such as Israel, seeing the same. So it's important to remember that COVID is a serious virus that causes harm and death. And of course, it's not just death that we have to worry about, it's conditions such as long COVID. And although we will need to look at this as the data emergencies, there's no reason to think that the vaccines won't be effective in preventing disease and therefore preventing the infection and therefore preventing long COVID. So this is about the full range of consequences of COVID. And then, of course, as Munir said, the clinical trials are designed to test safety. That's one of the key purposes of clinical trials, but it doesn't stop with the clinical trials. Regulators such as the MHRA, the EMA and the FDA are constantly looking at the safety of vaccines, as they do with all drugs after they have been licensed. We have very, very well established systems in the UK. The yellow card system is the one that's best known to ensure that that doctors, but also citizens can report in anything that it might consider a side effect of a vaccine or a drug, and the MHRA are looking at those all the time. So that is a constant process, and our regulators here and in other countries are extremely experienced at doing this and very effective at doing it.
Thanks, Steve. Ara, did you want to add to that, or does that cover it?
I think it's very adequately covered. And I must say, I mean, the FDA results recently, the American data is even better than we've ever seen before when it comes to the AZ vaccine. So no, it's I have had COVID. I don't recommend it to anyone. So get your vaccine.
Thanks, Ara. So Ian and Andrew. Ian Dodge.
Thank you. I just wanted to pick up on the inequalities point. So notwithstanding the challenge around differential uptake that still exists, certainly in the 28 years I've been working in health, I've not seen a similar program really forensically focus on inequalities at the scale with the level of data and the level of innovation that we've had in the COVID vaccination program. And certainly the National Inequalities team will think it sets a new benchmark actually for what we should now be doing across all of our programs, whether that's cancer, early stage diagnosis, detecting hypertension in the community, or looking at differential waiting times for elective care. And that's exactly what the planning guidance, I think, provides a focus on. How do we really leverage out of the great work you've been doing, Emily?
Thanks, Ian. Andrew Morris.
Thanks, David. Emily, as we kind of look towards the autumn, do we know yet whether we can give the booster jab, the booster COVID jab, along with the flu jab at the same time? Because clearly that would be fantastic news if we can.
So there are clinical trials going on at the moment that look at the coterminosity option, Andrew, but also the nature of what a booster jab might look like, and whether that's a different vaccine or a different vaccine type, and all kind of variations of that. So those are already in progress, and we'd expect them to report over the sort of early to late summer. I don't know if Steve wants to come in about what I'm not currently sure. We're going to have the data very much in advance of being able to plan the autumn. So we have a base case scenario and a variable scenario about whether we can give flu at the same time or not. Steve?
Yes. So currently the Green Book, which is the handbook of vaccination produced by public health colleagues, recommends a 7-day interval between the COVID vaccine and a flu vaccine. Clearly, we're out of flu vaccination season at the moment, but that was a recommendation. That is not necessarily based on studies, because those studies haven't been done yet. It's based on caution, but it is quite right that those clinical studies are done, and there is no overriding reason to think that it won't be possible to co-administer need to test that in a clinical setting. That's being done. Hopefully, we will get readouts in the summer in time for the programme in the winter. But I think there are other factors in play around how the flu and COVID programmes interact next winter, including whether how long immunity lasts from current vaccines, whether there will need to be new vaccines against the various variants that are emerging, and all that will play into how those programmes interact. We are planning on the basis there will be an interaction, but the scientific questions, there are some scientific and clinical questions that are outstanding that I don't think we will know about until we get nearer the summer to really nail down how the two programmes will work together.
Thanks, Steve. So Emily, maybe just one last question from me, that if you had to pick out one thing which has really inspired the success of this rollout programme, what would it be?
That's a really difficult question. I've been talking to various other countries about their, sharing between our programme and their programme, and I actually found it on 4 things, David, if that's okay, but I'll pick one of them out at the end. The first is that we started from a great foundation, both of the work the Vaccines Task Force did to bring the vaccines and create this portfolio of vaccines into the country, and the work of JCVI and the MHRA as sort of independent bodies to really dynamically review the data and give that independent clinical advice. So we started off with that very clear position. The second was designing the programme from the beginning along guidance from the World Health Organization that said, what does it take to make large-scale vaccination programs successful, which centered on having that really simple set of guiding principles so that the program is perceived as fair and straightforward. And obviously we got that based on the guidance from MHRA and JCVI, and then executing operationally brilliantly and as much as possible flawlessly, although it's not actually possible to do it flawlessly, because just in that act of operation, in the smooth experience people almost always have when they arrive at a vaccine centre, the friendly response they get when they arrive at a vaccine centre, the good experience of booking at the National Booking Service, which Andrew outlined in a previous board meeting, that all gives confidence both in the programme, but obviously then also in the vaccine by association. So designing ourselves so that we could deliver operationally effectively every day and learn every day from the data and then improve for the following day. So we built that foundation of operational delivery based on those World Health Organization principles. The third thing, which we've talked about in this meeting, is data, but not just the data, but the insight from the data. So designing from the beginning a system which allowed us to look every day at what was being delivered, to take the learnings from that and then develop accordingly or amend our approaches, as Ian outlined. And the final thing, which is the single thing that I would pick out in answer to your question, is the extraordinary mobilising force and delivery force that the NHS is. The combination of the sort of the idea of the NHS, the brand of the NHS, the people of the NHS, and that just unbelievable power of everybody coming together, not just NHS people, although it's a lot of NHS people, but everybody in support of the NHS, sort of whole communities grouping around a local delivery centre to marshal cars in the car park and to book appointments and to check people in and then to observe people while they're waiting, combined with the clinical leadership delivering the vaccine itself or the pharmacists making sure that it's dispensed appropriately. The whole kind of right from that micro level to the national scale that we've seen and that Simon outlined. I think we've relied on all of the aspects of the NHS and the tens of thousands of people that are delivering the programme every day. That's a major inspiring force every day, and something without which this delivery would have been completely impossible.
Well, Emily, that's a wonderful answer. And I might add that this wouldn't have been done without your leadership of the programme as well. So again, we say this every time, I know, but thank you very much for everything you've done to make this programme a success. Thank you. So I think we'll move on to the next item, which is the COVID-19 response overview. Simon, were you going to kick this one off?
Actually, I think Steve is going to, David.
Sorry, Steve, over to you.
Yes, thank you, David. So board members will be well aware that 2 days ago was a very poignant day. It marked the anniversary of the commencement of the first lockdown in the UK as a response to the pandemic. And I'm sure, like everybody here today, those of us that were in Skipton House spent a minute in the atrium, obviously socially distanced, but to have a minute's silence and to reflect on the past year. And I know many around the country, particularly in the NHS and our partners, did that on Tuesday. This paper sets out to provide an overview of the challenges that the NHS has faced over that year. It sets out how we've planned and responded to those challenges. Of course, it is by its nature a high-level overview. It can't and doesn't capture everything that has happened throughout the NHS at a very local level, at regional level, at national level. But I know that what it does give a sense of is just the tremendous effort that everybody has put in over the last year. And personally, I have just been overwhelmed by the passion, the focus, the dedication, and actually the sheer determination of colleagues throughout the NHS as they have responded to the pandemic over the last year, working together to ensure that patients with COVID and of course patients with other conditions have continued to receive the care that they need. I'm not going to go through the paper in detail because it's there to be read, but I might just point out a few highlights. So the first is that although we've been thinking about a year since March the 23rd last year, preparations in the NHS for the pandemic started a couple of months before. And as you will see in the paper, and as you will recall, the NHS stood itself up to a level 4 incident response, its highest level of incidents at the end of January the 30th last year. And indeed, since that time, apart from a couple of months in the late summer and early autumn, until today again, as you heard right at the start, the NHS has continued to be in that level 4 incident. I think that's unparalleled, and it just shows the level of intensity that the service has been working under. But it's easy to forget that prior to March last year, the NHS was deeply involved in working to support individuals through the pandemic. And I would highlight here the very early work of colleagues in Arrow Park in the Wirral to ensure that we could quarantine in a welcoming environment those UK citizens that were being repatriated from Wuhan and China, which was the epicenter of the initial pandemic. The second point I'd make is, and again, you get a sense of this in the paper, that we have taken the learning from the first wave in April and then translated that through into our response to the second wave that we have seen in November through to January, different ways in different parts of the country. January, February, at the time to start, we're beginning to see numbers decrease substantially, but we're still at the tail end of that second wave. A few things I would highlight there. So firstly, when we had the first wave, in preparation for the first wave in April, we stood down the substantial majority of elective care. And we did that because at that time it was really unclear just how many patients we would have to deal with. It was not certain how the public would react to those social distancing measures that the government had asked us all to do. And therefore it was important that we created the capacity to manage a large number of COVID patients. And of course we did that. But as we moved to the second wave in the late autumn and through the winter, we could take the lessons from that first wave. And of course, our data and understanding of this virus and how infection rates were evolving locally was much better. And therefore, in the second wave, we were able to keep elective services going in many parts of the country much more effectively than unfortunately we had to do in the first wave. And I think that again is testament to planning over the summer, but to the hard work of NHS staff. And then the second point I'd make is that we learned a lot about how to treat patients with COVID, particularly those who required ITU. We expanded ITU facilities over the summer, but we also learned about how you provide oxygen treatment to patients, such that we didn't necessarily have to ventilate patients that we needed to ventilate in the first wave. So that clinical and operational learning went into second wave, and along with something else I'll mention at the moment, you can quite clearly see that the proportion of patients who needed intensive care compared to a general bed in the second wave was very different from the first wave. The third thing I'd say is that although this paper focuses on the NHS in England, this is a worldwide pandemic. Of course, pandemics are by their nature global, and I think we should be proud of some of the things that we've done in the NHS, which will benefit patients everywhere. One of the benefits of the National Health Service is that you can stand up clinical trials rapidly, at pace and at scale, and indeed that has been done through the recovery trial and its various components. And fairly early on, very early on actually, in the course of a pandemic, that trial identified dexamethasone, an existing drug and a cheap drug, as an effective treatment for people with COVID. And by our calculations, that's already saved around 22,000 lives in the UK, and we believe probably around 1 million throughout the world. And I think that is a really clear example of how we can organise flexibly at pace within the health service and identify benefits which can then rapidly be expanded around the world. And of course, I won't go into any detail, but the second example, that is the vaccine programme, which we've just been talking about. And we have deployed the vaccines here particularly effectively, and I know other parts of the world will be looking at the methodology that we've used in that and looking at how they can translate it into their own settings. The fourth point I'd make is that although this paper isn't focused, well, it's focused on the response to COVID, as I've already hinted, we have during the year kept services going for all patients, and that hasn't just meant that we've provided services as usual, but we've continued to work on long-term plan commitments as best we can. And so it certainly hasn't been a year of focusing on COVID to the expense of everything else. We have certainly tried throughout the year to ensure that we continue to work towards improving healthcare and the health of the population. And if I could point out one area which is mentioned in the paper, which is in an area that I have responsibility for, it's in the creation of the integrated stroke networks, stroke delivery networks, that is a key component of the stroke program in the long-term plan. There are many other examples of that. So finally, what next? This is a paper that looks back, but right at the end there is a few paragraphs looking forward. And again, won't go into this in huge detail, but I think it is important to acknowledge that like many countries around the world, whether it's from the United States to our European neighbours, services have unfortunately been disrupted during the pandemic, and we have certainly seen that here. And so going forward, we need to recover those services. We did a great job, as again the paper documents, between the first wave and the second wave, but there is clearly more work to be done, and that will be covered elsewhere in the board meeting today. But it's very important that we do that, and I know our staff feel it's very important as well, because fundamentally we get up in the morning to do our very best for patients. But I think it's also important to acknowledge that in doing that, our staff have gone through an incredibly pressured year. They are in many cases exhausted, tired, and they need to recover too. And people recovery, our staff recovery, needs to be at the heart of service recovery, but because it's when our staff are working at their best and feeling recovered that they will be able to do their best for patients. COVID is going to be here for us beyond this last year. It's clearly something that we will need to learn to live with. There will be many ups and downs, I'm sure, during this year and beyond. But David, I think this paper gives a good overview of our response so far. Thank you.
Good. Thank you very much, Steve. It's a terrific paper. Could I, Ruth, you'd like to come in?
Thanks very much. Thanks, Chairman. I agree completely with what Steve has just outlined in a lot of detail, actually. So Thank you for that. The only bits of addition I would say is that I've been really impressed over this last couple of months, over a year rather, about the teamwork that people have approached this. It's been not just individuals, it's been how teams have come together, and actually hierarchies have gone in many ways, and people from across all sorts of disciplines have come together around the problem and worked together. And that includes our students, our medical students, student nurses, student midwives that stepped up too, as well as our volunteers, and of course the people that have come out of retirement. And I've been very grateful to all of those and worked alongside many of them during this last year. So my personal thanks to all of our NHS and care staff that have worked together to support the NHS and care sector during this last year.
Thanks, Ruth. And Steve, Ara, you're putting your hand up. Sorry, I couldn't see.
Yeah, I must say, I mean, as a board member, just to acknowledge what Steve said. I mean, if you look at the clinical trial contribution, 1 million NHS patients were recruited into a trial. That's an unbelievable achievement. Even the New York Times wrote about this. You know, it put the whole of the, you know, the Western Hemisphere, UK's contribution to at least 2 or 3 major discoveries of therapeutics that have had a huge impact on mortality post-COVID. Steve mentioned one of them. And that's something that this country not should be proud of, but also the NHS should be proud of. But how could we keep this? How could we keep this post-COVID? You know, this is the system that could do large trials of that nature. I think also I mean, people forget, by the way, even us who work in the NHS sometimes don't get this. You know, Steve, as I said in the paper, twice as many non-COVID patients were treated during all the peaks throughout the whole period since COVID started. There is this perception that everything was COVID, but it wasn't. And that's, again, big, major congratulations to those. On the trial side, by the way, it wasn't the scientists who did trials. It was NHS doctors and nurses and management who supported these. This is the bit that we forget. It's the doctor who sees the patients who decides who needs to be recruited into a trial. We need to acknowledge that, not the trial, what we call the principal investigator, which obviously they have an important role, but that's tremendous. And I hope that we will keep building the public confidence what the NHS could do in terms of trials. Also, by the way, some of the stuff that NHS England commissioned through, like, you know, COVID, the virtual COVID wards in the community, the COVID pathway, the pulse oximeter, that is innovation. That is really, truly innovation, which has had an impact more impact in the second peak. So these are things that we should celebrate and remember because at a time of serious strain, that is where the creativity of the NHS staff really did shine across the system in the UK and globally.
Yeah, thank you, Aaron. I think it's really shown the benefits of a big single payer integrated system, and also the fact that this extraordinary cooperation and partnership between pharmaceutical industry, academia, the government, the health and the healthcare system, which is, I think, pretty much unparalleled certainly in my time in the NHS, which is now around 20 years. I've got Ian Dodge and Munir.
So just a further elaboration on the teamwork point. Certainly the NHS England board came together in January 2019 to discuss our 5-year plans for general practice, including then the very first national funding for primary care networks. And we had big ambitions for how they would evolve over a 5-year period. And I think one of the things that the pandemic has massively demonstrated is the critical importance of the PCN platform, not least in relation to the last agenda item around vaccine delivery. And rather than the pandemic response meaning that we have to defer a number of our key long-term plan deliverables, that is a really, I think, brilliant example of how it has hugely helped accelerate their practical development. Thank you, Chair.
Thanks, Ian. And Munir.
So, thanks very much, Chair. So I completely agree with what Ara has just said, but I just wanted to thank members of the public and patients admitted to hospital taking part in the trials. Without them, we wouldn't have achieved any of this. So really do need to thank the members of the public.
That's an excellent point, Munir. There was, as Ara said, there were a million people, over 1 million people have been involved in these trials. It's extraordinary. David Roberts.
So I think there will be tons of lessons for us to learn and lots of ways in which we can accelerate change. And I think we need to really think hard about we take those lessons and bring them into our everyday operating practices, whether that's how we make decisions, whether it's the power of system working, whether it's the use of technology, et cetera, et cetera. And I think we really need to be quite intentional about how we bring those learnings into our sort of, because to some extent the biggest challenge is perhaps ahead of us, which is recovery, and we'll come on to that later. The thing, there's just a very brief angle, David. It's a story, and it comes back to team working, but it's also about culture. I was watching a television programme, I think it was about a hospital in East London, but I'm not sure. I think it was Clive Myrie did a report, and there was a gentleman there who in normal circumstances would be called a cleaner. And he was asked, what do you do? And he says, I'm part of the infection control team. My job is to make sure that this place is free of infection to allow the doctors and nurses to look after people and make them better. And do you know what? That really struck a chord with me about that. I'd like to say thank you to that gentleman and to all the other gentlemen and ladies in that sort of part of the porters, the cleaners. They're all part of the infection control and the patient sort of service. And they're all quite often forgotten, and yet they're critical. Things don't work without them. It's true in general practice as well. So thank you to them. They're part of the team as well.
That's a very excellent point, David. And Prerna, I know you're on the call as well. And this is what inclusion is all about, actually. So I'm sure you would agree with that. Are you there, Prerna?
Yes, I am, David. Thank you. And thanks, David, for saying that, because one of the things that we focused on in everything we've done is exactly that: equity of access, equity of involvement, of information. I had convened and I have regular discussions with an estates and facilities roundtable for precisely the group of people that you've just mentioned, David. And, this is whether it was staff protection, which is about, PPE, training, information, and now staff protection through the vaccine uptake. Every member of the NHS team is absolutely crucial and critical. And one of the enduring legacies of our COVID response across the NHS is going to be actually how it is one team. And all of the 350 roles across the NHS, make it all work and create the patient outcomes that the team has created over this year. So I would like to add my thanks and just reiterate that the person who you met from the infection prevention and control team, I love that as well. It's our equivalent of, the janitor in NASA putting the man on the moon, and that's really inspiring. Thank you.
Yeah, thanks, Prerna. So Steve, if you want to just have a last word on this before we move on.
No, I think the team point that Ruth made and others have built on, I think, is incredibly important. And we've always worked in teams, and those of us in the health service know that team is a very extensive team. I think at one point, I think it might have been at one of the press conferences, I talked about when I was at the Royal Free and part of the response to Ebola in the Ebola unit there. It was the engineers that kept the huge plant that is required to do the air cleaning for those beds, who were some of the key people, the unsung heroes. And the Evening Standard, I remember, took a photograph of the team, and about 40 people involved in it. And of course, those that were left out, and it just emphasises that this is not doctors and nurses, allied health professionals. It's managers, it's porters, it's the engineers, it's the catering teams. It's everybody pulling together, and we should be proud of all of them. So,
Steve, I know you won't take this the wrong way when I say that I think we all hope that we'll the less we see you on television, the better going forwards. And I mean that in the nicest possible way, because it means that the pandemic will be over. But you've done a wonderful job representing the NHS and the country as a whole over the last 12 months. Much appreciated. So thank you very much. So can we move on then to the operational and financial update? Amanda.
Thank you, David. And I think this picks up very well, actually, from the conversation we've just had, because as we've just noted, the NHS has been through actually the most pressured period over this last quarter because of COVID than we've seen actually over the whole of the year since COVID began. I know everyone's very familiar with the figures, but 34,000 inpatients at peak, 4,000 patients in our COVID positive patients in our critical care facilities. And as Ara said, and I think this was such an important point, and thank you for making it, still, of course, treating 2 non-COVID patients for every 1 inpatient with COVID through that period. I think it's worth just taking a moment to build on what Steve and others have said about, I suppose, what it was that enabled the NHS to do what it has over the last quarter. And clearly, the absolute answer to that is the extraordinary dedication of staff, as we've just discussed, from all different backgrounds and all parts of the health service coming together. But probably worth just highlighting a number of other things, actually, sort of working between the 2 papers. So what we did centrally is invested 237 million in critical care capacity. That's proved invaluable through the last few months, as we've seen the pressures on critical care in particular rise. 10 million plus specifically for support for critical care staff, some of the colleagues who've been, hardest hit by some of the pressures over the last period. In relation to urgent emergency care, as Pauline has said before, 450 million invested in A&E capital projects to improve capacity and flow. We've had significant, led by Prana and others, support for our staff in place over this period. Health and wellbeing support accessed over 780,000 times, and the establishment of 40 mental health hubs. We've also seen our workforce grow, of course, and been delighted to welcome 46,000 additional whole-time equivalent staff. And as Ruth said earlier, that doesn't include, of course, the extraordinary and invaluable contribution from our students, as well as those people who have returned to work in the NHS, having previously moved on or retired. We've needed the capacity that we've been able to secure in the independent sector. Again, it's proved invaluable over the last few months and played a particularly important role actually in supporting some of our most urgent work. And I want to say a word about that in a moment. Again, others have said it, so I won't repeat, but some of the work that colleagues in primary care, Ian, Matthew Wynne, have led the development of new services like the oximetry at home, the COVID virtual wards, estimated, I think, Ian, that's now benefited over 100,000 patients since those were set up. And that doesn't include, of course, again, the support for discharge, which we know has made a huge difference in keeping beds available for those inpatients who needed them and supporting people effectively at home, equivalent, I think we're now saying, of over 6,000 beds freed up as a consequence of that funding and those services. So all of that package has, I think, been in place to support our extraordinary staff to do what they have been able to do over the course of the last few months. But I just wanted to pick out, if I may, one particular thing that I think is also worthy of note, which is the ability that the NHS has shown to maintain its most urgent services over that period for non-COVID care. And in particular, I'm thinking really of cancer. So by December, we were seeing urgent cancer referrals and treatments at a level that was higher than pre-pandemic levels. So that, I think, is testament to, again, the great work that the National Cancer Team has done, supported by cancer alliances throughout the country and clinicians on the ground, as well as our colleagues in primary care, encouraging people to come forward, referring them on. And it gives us a very different platform as we think about recovery than we would otherwise have had. But now, and again, Andrew, you called it out earlier, now that the pressure from COVID is reducing, thank goodness, though we're conscious, of course, of the fact that it hasn't gone away and isn't going to anytime soon, we do turn our attention absolutely to the challenge of recovery. That is particularly challenging in relation to elective services. So we have figures that are now, I think, worthy of pause when we think that we've got 300,000 people who are now waiting over a year. I mean, that is just in itself, makes you realise the scale of the challenge ahead of us. But I don't want to just make the mistake of allowing us just to think about the elective challenge, because we also have a recovery challenge in relation to mental health, learning disabilities, and relation to primary care and community services. No part of the NHS has been untouched by the experience of the past year. But David, I wasn't going to take us through the detail of the paper because I think hopefully it speaks for itself. But I did want to just hand over to Pauline to say a few words, particularly about the approach to recovery.
Thank you, David. Amanda, if you don't mind, I'll just start off by saying a little bit more about emergency care, because I think I'm very mindful, following the comments made by Steve and indeed by Ara, that throughout all of this period, emergency care and indeed elective care and all of the staff who work in those areas have continued to really deliver what can only be described as sort of operational excellence, whilst focusing on transformation, on new ways of working, on new models of care. And I know that those staff would also want us to acknowledge the other stakeholders that help them, the returners, the volunteers, etc. But just one or 2 points around emergency care, that clearly we are now seeing numbers increasing. We had seen a significant drop in attendances over the period of the year. But if we look at February's numbers, we can see an 8% increase on January, and likewise admissions is starting to increase. But our 4-hour performance still remains better than it was this time last year, and then that it's been for some time. Also, I think it's worth calling out the excellent work done by 111 and the launch of 111 First. And if we look back over the course of the year to January last year, we've had an increase of about 3.2 million calls, etc. We established the COVID response service and really maintaining excellent call handling times and increasing the use of online 111. Now 34% of people who contact 111 who are sent to an emergency department are actually given a booked appointment. And I think that that is truly transformational, and we expect those numbers to increase as the service is rolled out and as more resource goes into it. I suppose interesting to note, and maybe just to call it out while we're on the topic, the significant decrease in the number of people contacting 111 over this period with winter illness, down about 84%. I think it's just worthy of note. But just one or two other quick things on emergency care, calling out the performance of the ambulance service, that year to date, all 6 standards, the delivery against them has been higher than in the preceding year, and real progress being made around see and treat, hear and treat, non-conveyancing to hospital. And I think the ambulance services, all 11 of them, are a real exemplar as far as mutual aid, working together, and indeed working with other emergency services to support them during difficult times. Amanda's already mentioned capital. Just moving on to what I was asked to talk about around elective care. Clearly, as Amanda set out, our waiting list is about 4.5 million. And as Amanda mentioned, 52 weeks, around 300,000 at this point. So clearly that's an area that is taking our focus on a day-to-day basis, and I think throughout the whole of the NHS. As far as recovery is concerned, we will have the benefit we truly believe we will have the benefit of our new operational arrangements, and that we will deliver elective recovery through those systems, etc. So basically providers, commissioners working together within a system in order to look at the waiting list, mutual aid between them, and indeed systems working together within regions and further afield. Our focus right now is on looking at the amount of work that our systems will be able to do over the course of the next 3 to 6 months, whilst absolutely acknowledging the fact that our staff will need some downtime. And I'm sure, like all of us, they will be looking forward to some sunny days when they can take a break from work. But looking at the work that can be done, and then also having some additional investment available through the £1 billion to see the total amount of work that can be done to ensure that we are addressing the needs of our most urgent patients, our P1, P2 patients, but also thinking carefully system by system as to the work that can be done with regards to long waits. The independent sector will remain part of that picture, and indeed working with a number of stakeholders, including our colleges, etc., on clinical validation and on ensuring that we have constant review of all patients. We're also working through our elective task force with patient organisations, etc., to really understand how we can best communicate where we are with individual patients as far as their care is concerned when they are having to wait longer than they may have had to do in the past. So I think we'll say a lot more about elective recovery in future meetings, but that's just a quick summary for today.
Thanks very much, Pauline and Amanda. Amanda, I wonder whether you could give us any information on a bit more information on mental health. I mean, anecdotally, I think we know that the mental health of the nation has deteriorated considerably over the last year. Have we got any, and I know we are planning to spend more money on mental health and provide more services, but have we got any, is there any hard sort of assessment of the mental health issues that we are now facing as we come out of, as we slowly come out of the pandemic?
Thank you, David. It may be that Julian wants to come in specifically on the funding settlement for mental health. So it's a 500 million for both services and workforce, but I think let's let Julian speak more about that. In terms of the impact on mental health, so we saw after the first wave of COVID an immediate increase in demand for mental health services. And then we know from all of the evidence internationally around trauma that you would expect, if you like, a sort of second surge about 18 months later. So, of course, as you'd expect, you're beginning to see that again. So the immediate demands on mental health services haven't gone away. They've continued, they're growing. But I think the thing that our mental health colleagues would want us to be aware of is that we need to be thinking about this as a long-term, not just a short-term increase in demand. And the other thing that I think, again, our mental health colleagues would want us to be really thoughtful about is the impact on children and young people. So that is the area where I think now that schools have returned, we would be looking to see, and in fact, I think there are early signs we are beginning to see, again, increase in demand, and that is at the most acute end. That's on the tier 4 children, the inpatient capacity, which is an area that the team are giving a lot of focus to at the moment because that is under significant pressure. Eating disorders is another area that we're really seeing increase in demand around, and that's on top of the kind of if you like, the slightly more routine community presentation. So there are figures in here about impact on things like the waiting times for IAPT, but the critical thing for us is, I think, maintaining the commitment to the mental health investment standard, making sure the money gets where it needs to, and then it's the question about how we use the extra monies that government have allocated and how we prepare ourselves, as I say, for that future surge and the particular pressures on children and on children and young people's services. But Julian, do you want to just give an update on where we are with the financial settlement?
I mean, yeah, sure. So, I mean, as we'll talk about in the planning side, I mean, recognising the commitment and need to expand mental health services even before COVID, we will be proceeding with insisting on everyone meet the mental health investment standard. We'll continue with the planned level of transformation funding into mental health, and we're in the process of just finalising the details with government for the extra investment in mental health and NHS workforce, the results from the £500 million announced in the spending review. And that is very much, from a mental health service perspective, geared to meeting some of the increased demand we've seen, in particular around children and young people and eating disorders, as well as accelerating, therefore, some of the service expansion we had already planned through the long-term plan. And we are just, as I said, in the process of finalising bits of the detail.
Thanks, Julian. Well, can we move then, Amanda and Pauline, thank you very much for that. But can we move into the financial position at the end of month 10 and then move straight into the planning guidance, please, Julian?
Assuming board members have read the paper, it shows very much, I want to say, sort of steady as she goes. We will have spent over £12 billion at the end of month 10, more than the original mandate, which has funded both, the impact on core NHS services that result from COVID, the much higher, covering the much higher levels of staff sickness or absence, the additional services that we have procured through the independent sector, the extra funding into discharge that we have talked about, extra funding to hospices, all the necessary steps that we've had to take to deal with COVID. But that kind of run rate has been very steady. Clearly in the acute sector, as activity has increased through the autumn, I mean, largely both the recovery of non-COVID, non-elective and other elective activity, and then through December and January, as we dealt with the spike in COVID cases in hospital, you have seen a gradual sort of tick up in marginal costs in that sector, but offset by a recovery of other income. So in aggregate, a very steady spend rate, which will actually continue through month 11 as well. And on capital, I mean, clearly we have put quite a lot of extra capital in to deal with some of the critical infrastructure, expansion of A&E departments pre-winter to deal with some of the extra demands we saw and the impact of social distancing, as well as progress on eradicating mental health dorms. So all of that is in train. I think the kind of impact of January and February, some of the social distancing, the uptick in COVID will have had an impact on the delivery of some of those capital programs inevitably. So I suspect we will slightly underspend at the end relative to the allocation made, but but it's actually, people have largely kept those programs going. Worth saying, and we'll come on to it, of course, we have reached agreement for funding for the first half of the year with government, which we can come on to when we deal with the planning item.
Thanks, Julian. Does anyone have any questions for Julian on the current financial results? No, I think, Julian, we can probably move straight into the planning guidance for next year, please.
So, David, look, clearly we're looking for agreement to the planning guidance, which we will then publish after this board, if it is agreed, out to the NHS. Firstly, it's worth saying the guidance we're about to issue has been the result of a lot of consultation and co-creation with people across the NHS, with national bodies, for example, the mental health charities, or the work Steve does around cardiovascular disease. So an enormous effort from a lot of people across the NHS and sort of associated partners. Fundamental to it is the funding agreement reached with the government that builds on the additional funding announced in the SR for elective recovery and for mental health and workforce development, as well as at that point the additional $1.5 billion they provided into our kind of baseline funding. As the Secretary of State announced, we've agreed a further £6.6 billion for the first half of the year, which recognises the extra costs we carry as a result of COVID and the ongoing kind of constraints we face as a result of continuing to sort of manage COVID, even whilst actual demand, in particular in the acute sector, has reduced over the last couple of months. The plan sets out the steps that we need to take to recover, particularly elective activity, but in other sectors as well through the first half of the year. The steps that we are going to take, though, not just to sort of go back to what was done before, but to use this to build on what we've achieved through COVID in terms of actually the transformation of outpatients, the much greater use of virtual consultations in secondary and primary care, and indeed in mental health, and some of the other innovations that we have seen. And I mean, what we've seen is the sort of need to double down actually on the investments we had already planned to make in things like extra diagnostic capacity to improve our cancer outcomes, or the expansion in mental health that we've just spoken about, or indeed the extra investment in primary and community care so that we're caring for people in the kind of optimal setting. I think the recovery from COVID both shows that those things are still necessary and will be an even more important part of how we recover over the next 6 months and year. Whilst the plan largely sets out the priorities for the first half of the year and the funding settlement that backs it for the first half of the year, we are giving clear commitments for additional funding into mental health, primary and community care, and some of our other transformation funding for the whole year, so that we really can get on in confidence with the service expansion we had planned and which is necessary. The first item, clearly a core part at the heart of what we need to do over this next year, just reflects our staff. So the planning guidance sets out some additional investment into national health and wellbeing services, so a continuation and expansion of what Perena's team have successfully put in place over the last 12 months. It absolutely, through the financial arrangements we've put in place over the back half of 2021, will allow organisations to enable staff to carry over unused leave and give the flexibility to staff as to how they choose to take that. And it allows the continuation and expansion of some of the workforce supply measures that we have put in place through 2021, which I think will continue to be a critical part of the recovery and plans into 21-22. And we have worked very closely with Health Education England and their business plan to ensure that kind of our workforce plans and the kind of future supply are lined up, because again, that's going to be a critical part of the expansion of mental health, cancer, and various other areas. So that absolutely at the heart of what we're doing. Secondly, it sets out the plans for elective recovery and the incentive system that we have put in place and agreed with government, such that we can pace the recovery of activity sensibly, taking account of staffing needs and indeed the need for people to actually take some of their annual leave, but frees up systems working at a system level to think, how do they prioritise and put in place the capacity we are going to need to recover, some of the growth in waiting lists that we have seen, and how they can restore activity, as well as where we are expecting to see further progress in terms of transformation in the way we deal with outpatients, the closer working between primary and secondary care, both on referrals and waiting list management, and then getting systems to really think how we begin to transform our clinical pathways to drive better productivity and better clinical outcomes with the capacity that we have. It also clearly sets out cancer as a major priority for this year, both the restoration of the 62-day standard over the course of this year, progress in implementing the 28-day faster diagnosis standard, as well as investment to identify quickly those cases which, we have not necessarily, where we need to catch up on things like screening through the first part of this year, and we will put an extra £50 million into breast screening to that end. Clearly, as I said, mental health already an absolute priority for us, more so coming out of COVID. Absolutely, we will be expecting systems to set out their plans for the full 12 months for the delivery of the mental health investment standard, and we will want to see clearly the funding arrangements for all providers across those 12 months, so that we know that the funding is going to providers to expand services in the way we want right at the start of the year, backed up with the transformation funding, backed up with the extra funding the government announced at the spending review. We'll also be, as I said, setting out the extra investment and goals for the continued expansion of primary care. I think we are targeting about 15,000 extra roles in primary care by the end of 21-22. And, we are sort of re-establishing normal contractual mechanisms and looking at how through this year we can, in agreement with the BMA and GPs, introduce the new services. We were already under discussion with them through contract discussions and looking for them to prioritise the management of long-term conditions, build on what we've learned through COVID in terms of remote monitoring, virtual consultations, and the kind of transformation we're expecting to see through digital channels. We'll be putting extra ring-fenced investment into community services. We are going to prioritise investment in the kind of 2-hour crisis response. We see all of this as a critical part of making sure we're managing people in the right setting, moderating the pressure on emergency departments in the acute sector. We think that's going to be critical if we're going to then recover other backlogs. And as we've said, maintaining the investment in the enhanced discharge arrangements through the first 6 months, at least the first 6 months of the year, which we think have been worth about 6,000 beds in the acute sector and freed up about 10,000 staff. So again, a really critical part of our recovery programme. And as part of helping the emergency pathway, we will continue to evaluate the 1-1 first arrangements with a view to expanding them through the year. And we are going to ask for people to now complete the data collection, which will help inform the government's response to the clinical review of standards and the future direction on the urgent and emergency care pathway. So, look, underpinning all of this is going to be a continued focus on prevention in all of those settings. We will be putting in extra funding for weight management, smoking cessation, tackling issues people have with alcohol through this year. As I think we spoke about earlier in the agenda, we will push a real push on all of these programs on health inequalities, a real improvement in the data that helps us understand where there are inequalities of access and outcome by geography, by population group through the course of this year. And we see that as absolutely the heart of the way we want systems to look at the sort of population health need, and we'll be putting new investment into the way we support systems in sort of gathering that data. Then tied to that is clearly how we invest in digital transformation, improving provider digitization, but we are, through some of the clinical pathways, really exploring how can we transform care. I mean, really, sort of change it front to back, and we currently have a real focus on eye care in that, and underpinning it all, the move to system working, integrated care systems, in which clearly we are anticipating legislation in due course, and the further development of primary care networks. I mean, that's what the planning guidance sets out, the funding to back it, and if the board agrees it, we will publish it later today.
Julian, that's very comprehensive. Thank you very much. And Andrew, you've seen many of the planning guidance notes over the years winging your way when you were at Frimley, and no doubt other hospitals as well. What's your assessment of this?
So I think it's been co-created. So it's been, the other ALBs have been involved. A number of system leaders and trust leaders have been involved. So that's really positive. I think it's very clear in its messaging. It sets out some very clear priorities. So I think the service will have the clarity it needs to deliver some of the big challenges that it's got ahead of it, and capacity is going to probably be, and workforce, the two must sorts that we're going to have to tackle. And I'm more worried about the capacity issue than I am the workforce. And I think if we're not careful, we will see a dent in our ability to really tackle the backlog in terms of waiting list, particularly if social care is under the cosh financially in the back half of the coming financial year. So hopefully, as Simon negotiates the settlement, and Julian, for the last 6 months of the year, we can continue with the scheme that Ian has got, discharge to assess scheme. Because I think it's so important, given the massive beds that it's freed up for the service, and we need every bed that we can free up to handle the elective backlog. So I think the document reads really well. It's very clear. Most chief execs, I think, will be really supportive of this, and it sets the template, the must-do template for the coming financial year. So I think it's very clear. It's good.
Thanks, Andrew. And Patrick, particularly focusing on the incentives that are built into the plans to reduce to attack the sort of the elective backlog. Do you think that gets about the right balance?
Yeah, I think it does, David. And I think the two-step approach, ramping it up gradually, recognising we just can't sort of turn the tap on immediately. But we certainly need to keep focused on these incentives, because we do need to get all providers really cranked up as we come out of this. As Andrew just said, the backlog is going to be the big challenge we face. And we're going to have to do everything we can to organise to overcome that. So I think this is one of the best documents I have seen in this, and I think it's a great way forward. And probably the most important thing is we've got the money to deliver it. So really important.
I think the narrative feels right to me, Julian. It is much more moving towards systems. There's a big emphasis on health inequalities. I think it's a terrifically high quality piece of work, to be honest with you. So look, could you thank all your team? I know you, if it hadn't been, you'd have got the blame for it, but I mean, you can spread the praise around. But before we do that, I better just ask the board whether they are going to approve it or not. Can I assume that, unless anyone says otherwise, that we're in favour of this, and it'll be published later on today? I think it's a really first-class piece of work, Julian and Amanda. Thank you very much. So can we then move on to the system framework then, Amanda?
Thank you very much. So similar request to the board, which is to approve this to go out to consultation. So slightly different process around this. But what I wanted to do was just draw attention, if I may, to the kind of two big things that have changed. And I'll just say one or two other things rather than get into a lot of detail. First thing to say is the big change is this now reflects a single framework that brings together providers, CCGs and systems into the same single oversight framework. So it builds on where we were before, which had done a similar job for providers and CCGs, but this adds the system lens. Second big change is that it is proposing replacing the separate provider-focused quality special measures and financial special measures regime with a new recovery support programme focused on individual organisations and or systems, but taking a much more integrated approach. We have developed this, thank you for those of you who've been involved with us, but we have developed this also with NHS leaders, stakeholders, including the CQC, and with system leaders. And this does also reflect, just to the earlier conversation, an increasing role for ICSs in the oversight process, linked, of course, to their maturity and development journey. So just a few other things I wanted to call out. This framework proposes a single national scorecard looking at 5 sort of oversight themes which are aligned to the long-term plan. The metrics will be drawn based on the 21-22 planning priorities, so links exactly to what Julian's just taken us through. But the thing we're also proposing is that there would be space in this framework for a 6th theme, and that will be determined locally. So finding the balance between consistent national framework but appropriate local flexibility to reflect local population priorities. Next thing I just wanted to mention was about the segmentation approach. So this again is a continuation of something the NHS has had in place for a long time, but it does move us on, I think, from something that perhaps felt like it was a little bit of a cliff edge with whether you were in or out of special measures, to something that offers a much clearer definition of support if you find yourself in segment 3, targeted support based on the best practice that we have access to within the NHS and our ability to call on colleagues, for example, in the GIRFT team, who can come and help do some of that pathway redesign and clinically led transformation work, or indeed specialist support around things like urgent emergency care, for example. And then segment 4 becomes the mandated recovery support programme, but with much less, as I say, of a kind of cliff edge between the two, and much more of a sense of being able to call on consistent support offer for all organisations, no matter where they are. But as I say, with a targeted support offer, segment 3, a mandated recovery support programme, segment 4. Final thing, David, was just to say the proposal at the moment is, if we approve today, we will go out immediately for consultation for 6 weeks, with a view then to implementation, but in a phased way this year, to reflect the uncertainties that we have in light of COVID, and with an initial focus really on getting, if you like, the sort of segments 3 and 4 sorted out, so that we can make sure that we're offering support in an appropriate and targeted way.
Thank you very much, Amanda. I was wondering whether, Tim, I mean, you'll see running through this a big focus on population health and on reducing health inequalities. I mean, from your own experience, do you think we've got the framework is about right?
I do. I think it's terrific. I think the direction of travel here is excellent. Of course, lots of work ahead, but it's exciting work. And I might frame this as adding one thing to what Emily Lawson said about the advantage that the NHS provided in providing such extraordinary vaccine coverage. And in the world that I live in, I am so envious of this and so looking forward to living in your world. And that is end-to-end control of delivery. That is something that doesn't exist in the US. And in an age in which we try to use particularly digital technology to improve service delivery and the generation of data for management, having a view of the entire process is a huge advantage. And so I see the coming together of the funding, the ICSs, the team, as has been discussed, the sense of team, with this view toward the end-to-end process as enabling local work on improvement that is the only way to scale, right? Because you can't scale with central authority. It has to be through local improvement. So I hope that was on point, David. That's my assessment from this side of the pond.
Thanks very much, Tim. And Laura Wade-Geary, that is. From a digital point of view, sort of do you feel that the digital transformation opportunities and the opportunities from using data are sufficiently reflected in this?
David, I think yes would be the short answer. I suspect that we're still on that journey about always embedding it. But I think I'd really call out Tim's point around what we've been very clear about, I would say, that the exec have been very clear about, is the importance of data to enable population health management and how we ensure that as ICSs come together, that is one of the key foundational blocks. So I think that we are, that seems to me absolutely key to the approach here.
Thanks very much, Laura. So, unless there are any questions, other questions for Amanda, can I assume the board is happy that this should go out to consultation in the way that it's been expressed in this paper? Yeah, Amanda, that's great. Thank you very much indeed. I mean, Simon, you must reflect back to when you first wrote your 5-year forward view, what, 6 or 7 years ago now, when you were just sort of positing this as a potential endpoint, I think.
Yeah, I think the point is that the clock speed of integration or joining up services has dramatically improved over the last 12 months through the pandemic, as we've talked about. But we will have got, 9/10 of the way there in organisational terms. The final 1/10 is what we need the legislation for, that we're expecting the government to bring forward during the course of this next parliamentary session. But from the other end of the telescope, it's all about the patient experience, and it's about using what we've learned around the vaccine programme to, in real time, design out inequalities in access and uptake, and doing that for cancer screening, for urgent cardiovascular care, for young people's mental health services, making that the new way in which the health service works. And I think people have now lived that even over the last several months on the back of COVID vaccine, and can see that that is the way we want to operate the service as a whole. And so all of this talk about, integrated care systems and governance and so forth, all of that is just a means to an end, where the magic actually happens, which is in the encounters between patients, the public and the health service locally.
Good, thanks very much, Simon. So Prerna, over to you.
Thank you, David. And many of my colleagues have mentioned supporting staff already, so I'll build on what people have already shared. So first of all, a huge thank you from me on behalf of the entire executive team to everyone who has worked so hard and responded in such an extraordinary way during this past year. The scale of response has meant that staff are tired, but also will share the examples of having transformed the way they are providing care, of teams coming together, of different roles, as we discussed before, contributing to this response. So our focus now is on supporting staff to recover. And before I go into some of the key elements we're focusing on, I wanted to recount a conversation I had with a medic at the Swami Narayan Temple Vaccination Center. And, we were both wearing masks and we couldn't really see each other's faces. But I asked Sapna, she's a medic in a critical care unit in London, how she was doing. And she said, actually, I'm really tired from my week. But it was a Saturday and Sapna was vaccinating. And I asked her, well, actually, shouldn't you be resting then if you're really tired? And she said, actually, this is giving me so much energy. I'm going to be here on Sunday as well, because the COVID vaccine and our efforts as an NHS to vaccinate the entire population is our way out of this year. And so I think her experience of both feeling tired with the year, but also feeling extremely hopeful and determined to see the next steps through and help reach patients who are waiting and look at activity recovery would probably represent a lot of people's experiences. So I was struck by that conversation. And so what I wanted to share is that we, in March of 2020, we had, along with local offers to support staff, put in place a national health and wellbeing offer that Amanda had referred to, which has now been accessed 780,000 times, which shows that people are focusing on accessing care. We had convened, NHS-EI had convened an expert advisory group in March of last year that has been advising us on how we can support staff on an ongoing basis. And every month in the last 12 months, we have added something to that national offer based on the feedback of staff. So for instance, we added a bereavement counselling service, we added a financial advice service because people had shared that they had secondary stressors in terms of what was happening with families. We added a bespoke bereavement service in different languages. We, of course, have lots of health and wellbeing apps that have been downloaded by more than 150,000 people. So we've built in listening into the process. We have had pulse surveys every month. And with that, we are constantly expanding and fine-tuning the offers from NHS-EI. But also, I know that employers have really made sure that they are supporting their staff as well. And the staff survey results of 2020 confirm this. So the staff have said that there's a greater focus on their health and well-being during the pandemic, and that theme has shown the greatest improvement across all of the themes in the staff survey. There's a 4.1 percentage point increase in staff feeling that their organization takes positive action on health and well-being. And I do believe that this will be one of the enduring legacies of the pandemic, that we have ongoing support for staff. However, there was also an increase of 3.6 percentage points in those staff who say they have felt unwell as a result of work-related stress within the past 12 months. That's in the staff survey as well. And with the worldwide pandemic and the pressure on health services around the world, it's no surprise that our staff have also had to respond in this way and feel tired as a result. So therefore, what are some of the principles of recovery, of well-being recovery, that we have been working on, and some of the actions that are already in train and more to follow? Our expert advisory group has said recovery needs to be individual for each person in the NHS, so that we can make resources available for the vast majority of people who would like to access those resources as and when needed. Our experts have also said we should be careful not to over-medicalize the support that we provide. So we are looking, we're going to make guidance and resources available for individuals, for teams, to reflect on the last year, process the year, but also then look at the lessons learned, the innovations that have taken place in the last year, and then look towards the future. Some of the things that people have said they have really appreciated and would like to take forward are flexibility in ways of working, reduction of bureaucracy, enhanced teamwork, and expanding some of the skills that they've had opportunities to work in other teams and other functions. So we want to make sure that we are providing that support to teams, and employers will as well, because research shows that our well-being depends on what is happening in our workplace every day and how our teams are coming together. So what we're doing is making sure that we are providing this guidance to all employers and supporting with the National Health and Wellbeing offer. What we're also looking at is the vaccination program being part and parcel of this wellbeing offer, which means the first dose, staff protection issue and a patient protection issue, the second dose, the flu vaccination, and so on. As Steve mentioned, we don't know what the COVID vaccine program and protocol is going to look like, so we would like to make sure that staff stay protected, in this process. What we're also doing is making support available to leaders and managers. We've had 20,000 leaders attend regionally led workshops. We have an offering of an executive suite for leaders for the COVID response especially, and we're going to expand that for recovery. We have something called Project M, which is aimed at managers. We know that managers and leaders have also had to shoulder new responsibilities and new challenges. So we have very dedicated support available for them. We have also set up a new role at the board level in the provider sector, which is a wellbeing guardian, and that role has been taken up by lots of organizations. And in our launch event, two launch events actually, we've had 450 NEDs attend as delegates, and the reason is that we want health and wellbeing of our staff to be a board level responsibility, and I'm really heartened by the kind of interest we've had from basically 450 delegates at the board level attending, and many having signed up for this role. We are also saying that every staff member should have a health and wellbeing conversation in the first 6 months of the year, and then regularly going forward. And this is because with the learning from the risk assessment conversations we've had in the summer of last year to keep staff safe, what we see is that we need this conversation to be regular, annual, and for every single staff member, so that staff can talk to their line managers about what they need to be able to do their work and job well. So it is something that we are going to be focusing on. As Amanda mentioned, 15 million has been invested to establish 40 mental health hubs, one for each system. 22 hubs are now live, which means that staff are able to access them. There is rapid self-referral. There is access to specialized mental health support. And that's really, really important, because there are a group of staff who are, of course, in need of more specialized support, and we want to make sure that they are able to access it. I think this was mentioned already, that the impact of the pandemic on critical care staff has been extensive as well. And so the hubs, the occupational health hubs and mental health hubs, are doing proactive outreach to critical care teams for support. And that's really important, so that we're not waiting for staff to come to us. We are reaching out to ask when support is needed. And there was a recent online briefing with over 250 clinical leaders participating. In addition, 400 critical care nursing staff are registered to be trained as facilitators of restorative supervision to their own colleagues. And the first training cohort started on 3rd March. This is a very new and innovative approach. And this has been advised by our expert advisory group, which includes psychiatrists, psychologists, experts from the military, etc., who have said that restorative supervision after this kind of year is extremely important for recovery. And then the last thing I will say is that the impact of this work of the health and wellbeing support is going to be evaluated on an ongoing basis through the boards, with the wellbeing guardian playing an important role, as well as we've had one independent evaluation already last year, and we will continue with that as well. So let me stop here, and very happy to take questions and have a conversation. But again, my thanks to all staff in the NHS. And also I would like to tell them that research says healthcare professionals are amongst the last to seek help, and I would just encourage everybody that there are resources available for you. Please do access them. Thank you.
Thanks, Prerna. Well, that's a very, very important message for you to finish up on. So any questions for Prerna? I wonder whether David Bean would like to come in here, and then I'll come to Wal.
No question, David. Just to support what Prerna has set out, we've put in place the people board and the architecture around that, which is one of the ways to bring all key stakeholders and partners together to support this work. And I think this emphasis that has run through today's board meeting really about collaboration at a national, regional, system and local level is the one that I'd emphasise around workforce, whether it's a workforce supply or whether it's supporting the workforce that we've got in terms of retention and some of the measures that Prerna has outlined. And I think that adage that we're stronger together has never been truer, to be honest. And I think it is essential that we work together. And Prerna and Navina from HE have been working together on chairing the people board, and Andrew Morris and myself and Lee McDonough in the DH provide that sponsorship support to that. And we had a very good stakeholder meeting last week, I think it was, which brought together, I think there were 100 people on the call representing these key stakeholders. It's such a complex landscape, David, and creating the preconditions for success, in my view, means that we've got to get this collaboration at a national level. And I think what Prerna's outlined is absolutely to the point. And just to echo what Julian said when he was introducing the planning guidance about just how important it is we work together to secure the workforce for the future, but also support the workforce of today. Thanks, David.
Thanks very much, David. Wal?
Thanks, David. Prerna, great paper. Lots of very important and issues been brought up, and lots of interesting interventions. I think for me, I'm just going to look forward and frame this by saying, I think anyone in business running any sort of organization recognizes the draining of social capital that's occurred over the last 12 months. And that's partly through not just asking people to work harder and more innovatively and change and embrace change, but it's also to do with the fact that they're working in unfamiliar environments. And I know people say working from home is great, but it's an unfamiliar environment to work in. We're now going to try and recover and come back to whatever the normality is that we come back to. And I just want to make sure, Prerna, that in your thinking, this is a permanent, hardwired activity. Because to recover the social capital we've drained, a whole range of things, some of which David touched on, other people touched on through this board meeting. But this health and well-being as a point to focus on will need to keep going on and redoubling efforts to make sure across the whole system, people are constantly thinking about this. Because the danger is we go back into normality, a year out, 2 years out, we forget about it. Or it gets downgraded and downgraded every year. So for me, the question to you is, what can we do to hardwire this in? And by the way, that's an invitation to ask the board to be held accountable for this.
Do you want to respond to that?
Yes, absolutely. Thank you. Thank you first to David Behan for your painting of that picture of collaboration, which is absolutely right and you know is I was going to say felt reality, lived reality or felt reality, and it has really, I think that the acceleration in collaboration over the last year has been phenomenal, and we are all going to be focused on keeping it that way. Well, absolutely right. And how I'm thinking about it and how I'm thinking about it with leaders is that from a program approach, so health and well-being sort of as a program, to making it the way people manage and lead, and the way people come to work in the NHS. That's the arc that we are focusing on. So the kind of inputs we're putting into the line manager programs, training programs, for instance, the leadership inputs, it has to be the way managers lead and the way teams come together. It has to be the way we work. So what we don't want it to be is a program for too long, because then, as you say, it can slip by the wayside. So, of course, the resources will be available, but it has to become a manager's role to make sure that their staff are well. How do we design for that? How do we train for that? How do we recruit for that and assess for that? So that's really the focus of actually the recovery, the planning guidance that Julian has outlined. The first priority is staff well-being and recovery, and I think that's such an important signal to everybody in the service. And then, as David mentioned, Navina and I are co-chairing the National People Board, where we're looking at the People Plan 22 and beyond. And that this is actually one of the big focus areas for us for that as well. So just to underline and reassure that it's very much part of our longer term focus. But I would, it would be great for us to have a continued dialogue about this as well. Thank you.
I think, Prerna, Amanda made it very clear discussing the operating model earlier that the people and culture are fundamental to delivering to our whole program. It's so important. Could you just touch a little bit on the work you're doing, the revitalization that you've done with the RES, and also the results of encouraging people from BAME backgrounds into more senior jobs in the NHS?
Thank you, David. So the paper that's part of the board papers on the NHS England and Improvement 19% goal progress, which is Sir Simon made a commitment a year ago to have 19% representation of BAME colleagues at all levels of NHS EI in the next 5 years. And this is it's actually a really ambitious aspirational goal, rightly so. In other parts of the NHS, the RES goals are over a 10-year period. And it's right that as the arm's length body, that the NHS England and Improvement has taken on a more aspirational goal of 5 years. So we started last year to look at what are some of the interventions that we need to do to take away some of the barriers to that goal, as well as support all colleagues to make this a reality. So I just wanted to point out a couple of things that we've seen in the last year. One, that focus on data and having transparency across leaders has really helped us to make sure we're holding ourselves accountable for moving towards this goal. We've done that through overhauling recruitment practices, using data and analytics, and as I said, leaders taking real ownership for the outcome. And that has been a key focus. Also, not having lots of different things for us to do, but really being, prioritizing this aspect. And that's been the experience of other leaders in the service as well. That if we focus on one particular ambitious goal, there's more progress made. So we've also had a couple of other things we've done: full transparency of all assignments that have been available. So whether it's opportunities to step up, different projects, and of course in the last year there have been so many opportunities for colleagues to do that. So there's been transparency of all those assignments. We have conducted talent conversations with all BAME colleagues in NHS England and Improvement, between them and line managers, and this will be expanded to all staff this year. We've been making changes on multiple fronts: policy, practice, and behavior, especially leadership behavior. So what we've seen is that in the very senior grades, so ESM level, there's been a 3.5% increase in BAME staff over the last 12 months. And at band 9, this is another 3.5% increase. So that's quite significant. And the positive is that it has been done with a real shift in culture. And, we want this to be a sustainable shift, and a shift where not only do the numbers change, but the culture changes as well. And that's what we are trying to do by intervening at all, in all different levels. So in a year, this is quite a significant shift. Switching to the RES report, which is the last 5 years, we published, the RES 2020 was actually looking over the 5-year period. What we see is that there are a couple of indicators out of the 9 indicators where we've made progress as the entire NHS, and board membership is one of them. So it's at a high of 10% right now. And also the difference in disciplinary proceedings across non-BAME colleagues and BAME colleagues. So that gap where you were much more likely to be put through disciplinary proceedings if you are from a BAME background as compared to white colleagues. That gap has been narrowing, and in 51% of organizations in the NHS, that gap is now at 0, which is really, really positive, but still, I mean, it should be 0 everywhere. But, you know, progress on those 2 indicators. In the other indicators, there hasn't been that much progress. And so what we are doing right now is undertaking a best practice review from those trusts which have, so no trust has really positive results on all 9 indicators of the RES, but there are bright spots in different indicators, and we are working with those trusts to identify what we should do. The first step which is in the planning guidance, is action on overhauling recruitment practices, and that's been the NHS EI focus as well, because it's, you know, somebody shared this analogy with me, which I just found really powerful, which is that there are fences, you know, and people have to leap over them. We could give people higher ladders to leap over the fences, or we can take the fence away. And so overhauling recruitment practices is very much about taking the fence away and having a level playing field than saying, please try to climb higher and higher fences and here are more ladders. So that is already in the planning guidance, and the RES is going to focus very much on overhauling recruitment practices for this year, but a 5-year strategy is following. Thank you.
Thank you, Prerna. I was wondering whether, Ruth, you had any comment to make on those.
Thank you. Well, nursing has always been a very diverse workforce, and I'm delighted to be supporting Prerna on this, not just within NHS England and improvement, but more widely. And we know that we've still got much more to do. There are some inspiring groups, though. I've got a Black, Asian and minority ethnic group of male nursing leaders, and they're just so inspiring. And when I met them this last week, 30% of them had got promotions in the last year. So there's some really inspiring stories out there. I think it's, as Prerna has just said, how do we make sure that we gather that across all of our organisations and all of our disciplines of our professions? Happy to support Prerna's work completely.
Thanks very much, Ruth. Prerna, thank you very much. That's a very excellent and inspirational report, so thank you for that. Shall we move on then to maternity services? And this has really come about as a result of Donna Ockenden's report into Shrewsbury and Telford. And I think, Ruth, you're going to introduce it, I think. Is that correct?
Yes, thank you. So there's a number of elements we want to cover here, the first of which is John Ockenden's report, which I'm going to ask Aidan to talk about, and then also the wider implications, setting that in the safety agenda. Second, of course, we'll ask Sarah Jane Marsh, as the chair of the Maternity Transformation Board, to describe what's been happening, and then I'll conclude on what actions we specifically have done and doing in response to Dr. Ockenden's report, and then I'll hand over to Simon Eccles to talk about digital. So if I can ask Aidan to start, please.
Thank you, Ruth, and thank you, Chair. I'm just going to blend the 2 elements of the 2 papers together, but first talk about the Ockenden report. And I think it's important to start by thanking Donna Ockenden for her work on this report, but also, and incredibly importantly, to thank the families who have brought this concern to our attention. Many of them have suffered loss in very difficult circumstances. This is a very challenging thing for them to do. And I hope what they'll see today is how seriously we take these issues and how huge the response is to this and has been over the last few years. We certainly haven't waited for this report to take action on maternity, but it's supplemented it. The report was commissioned by the previous Secretary of State, Jeremy Hunt, in 2017, initially into concerns raised about 23 families in Shrewsbury and Telford Hospital in maternity care, but subsequently has expanded very significantly, both as a result of more families coming forward, but also the Trust's own review of its notes into maternity. And the number now stands at 1,862 cases that are to be reviewed by Donna Ockenden and her very clinically based team. That is a huge piece of work, and it was important that we understood early on any issues that we could act on. And so a decision was made to write an interim report. That was published in December. You'll see, I think it's blurred, but you can see this is a relatively thin but very clinical and pragmatic report on the first 250 of those cases, which includes the 23 original families, and essentially a spread across the time period involved. Most of the cases are in the 10 years to 2019, but there are some more historical cases. That report made a number of recommendations, 7 of which were immediate and essential recommendations for the national maternity system. We have been taking steps to implement all of those and have accepted all of them at face value and supported them and worked closely with Donna on making sure we understand exactly the aim of them and the importance of them. In addition, there were 27 and significantly overlapping recommendations made to the Trust itself, all of which they've accepted and are implemented. The Trust is already receiving support as a whole from University Hospitals Birmingham at the instigation of NHS E&I, but in addition on maternity has formed a partnership with Sherwood Forest Trust, who have experience of making strides in improving their own maternity services. And I think there is a lot of overlap in those experiences. So I think that's a useful adjunct for it. And there will be a final report, which we expect later on this year, which will give much more detail about those 1,862 cases. We don't, however, in discussion with Donna Ockenden, expect a whole raft of new recommendations. And so we wanted at this point to get on and implement the recommendations made. It is important to note in this context that there have been very significant improvements in measures in maternity, measures of reductions in stillbirths over the last 10 years, and in neonatal and maternal mortality, as well as small reductions in brain injury. Those data tend to lag, and we are expecting more reductions in the future, and we are doing more work about that. But it is notable that there is more to do, and particularly around equality in these outcomes. So there's been a lot of discussions on this board meeting about inequalities in healthcare, no less in maternity. And it is a stark figure that Black mothers have 5 times the chance of a maternal mortality to white mothers. And we need to understand and work more on these disparities, and are doing so. I just also wanted to talk about the context of HSIB, which was one of the asks of where does HSIB, the Healthcare Safety Investigation Branch, fit into this agenda, and how does that fit to the wider patient safety landscape? So HSIB were not around at the time that this report was commissioned. So the first thing to point out is HSIB could not have spotted these problems in maternity, but they were not doing their work at that time. Initially, HSIB was formed to look at in-depth investigations. 30 reports a year was the expectation into safety issues across the NHS. Later on, the previous Secretary of State added maternity investigations, and the expectation is they would do up to 1,000 investigations a year based on the recognition that, particularly in the case of Shrewsbury and Telford, the investigations carried out for these cases were of poor quality and weren't acted on in a timely fashion. Now, there are less than 1,000 cases that would fit the criteria for HSIB's maternity investigations. There are probably about 900 a year that fit, and they have been, I think, largely very effective in doing very in-depth investigations of these cases, and have written reports on their conclusions, and have also importantly identified concerns in other areas that we've been able to act on much faster. So I would say that our response in the case of East Kent, where there is an independent review being carried out by Bill Kirkup currently, has been much faster and has not required families to have to fight and campaign for some time for us to look at those concerns. And they are notifying us of challenges where we see them, and we are acting on those, notably with the maternity services support programme that's been so important in supporting trusts that see challenge in maternity. So HSIB are part of our approach to assurance in the system. They are able to do investigations in depth. And they will be part of whatever happens next. So we have an NHSI responsibility for governance around HR, finance, etc. for HSIB, but the investigations sit under the purview of the Department of Health and Social Care. It is their decision as to what happens with maternity investigations, but I think many of us would like to see training and support around reintroducing those into the system, and over time, my expectation is that's likely to be what happens, and HSIB will be part of the support and training of staff to carry out those investigations alongside our own improved serious incident investigation process, referred to at the moment as PSIRF, the Patient Safety Investigation system, rather than the current safety investigation, serious incident framework, rather. Can you hear me?
Yeah, you went mute for a minute. Yeah.
Did I? Oh.
You've gone mute again.
My notes are pressing on the space bar. Apologies for that. I also have laid out in the paper how this fits with the wider patient safety system. And I think from the point of view of focusing on maternity, we are seeing some important changes, and I would expect Sarah Jane will want to talk more about the maternity transformation plan. In the current maternity transformation plan, patient safety sits as work stream 2 of 10 with specific focuses in this arena. What we're looking at is a new approach for the maternity transformation programme as it reaches 5 years to continue the work, in which we'll see, one, the design of the patient safety strategy reflected, divided into insight, knowing what's happening on in the system, which would include the HSIB reports. Also the infrastructure, that middle section, and you will hear more from Ruth about what that means for staffing, equipment and so on, and where investment is going into that very significantly, as well as the programs of improvement laid out in relation to antenatal care, intrapartum care and postpartum care, in a simplified system that we hope will be much clearer for people, and particularly for hardworking staff, to get their head round and engage with, as well as other elements. We're obviously clearly supporting very strongly on the work to spot deterioration and manage that more effectively, on culture, and also we are trying to simplify the way in the insights section reporting occurs. For example, up until recently, maternal deaths would be reported in about 7 different ways to different systems, which is hugely burdensome for staff to generate the same information. So we're simplifying that. So there's a lot of work going on to align the approach taken in maternity to our wider patient safety goals, to simplify it, and also to remove some of the silos. So patient safety will be a theme across the whole new maternity transformation programme, rather than a single item within it. At that point, I'm going to hand back to Ruth or on to Sarah Jane for further comment. Thank you.
Thank you. Sarah Jane, if I can ask you.
Thanks, Ruth, and good afternoon, everybody. I'm Sarah Jane Marsh, and I chair the NHS England Improvement Maternity Transformation Programme. Indeed, I've done that for the last 5 years, and next Tuesday we'll be celebrating 5 years of the programme and 5 years since the publication of Better Birth. So I just wanted to pause for a moment before I go onto the things where we know we need to do better, to focus on the things that we have done really well and that we feel proud of. And I feel I need to do that on behalf of the thousands of staff that work in maternity services across the country that are very proud of the achievement. So as Aidan said, we've seen a 25% reduction in stillbirths. We've seen a 23% reduction in neonatal mortality for babies born over 24 weeks gestation. We've seen a 9% reduction in maternal mortality. We've seen reductions in babies born with brain injuries. We've seen preterm birth falling, and we've seen women's overall satisfaction with maternity services never higher. And indeed, between the last 2 CQC surveys in maternity, we saw the biggest set of improvements of any clinical service in the NHS as measured through the CQC surveys. So we've been doing a tremendous job over the last 5 years, but we are the first group of people to say that there are also things where we know we've needed to do better. And in particular, throughout the whole 5 years, it's been laced with really some awful stories, as Aidan has described, where we know that in either individual pockets in services or sometimes across entire services, we have let women and families down collectively. And often we do see clustering. We can't say that they are related to just one-off incidents or isolated happenings. And so what we've done over the past year or so, really sort of building on some of the early findings from places, not just Donna Rockerton's review, but learning from places like East Kent too, where we know we've also had issues, is to try to understand the root causes of why some of these things happen and why some of the things that we've tried to do nationally, despite all of our best efforts, don't seem to have been able to have been applied universally. They've worked in some places, but somehow they've managed to pass some individual units and services by. And we've come down to 3 main root causes. The first is where we've got a poor leadership culture and therefore a poor culture in the service. Everything else becomes more difficult. Behaviours become difficult, transparency becomes more difficult. The units are less likely to implement the changes that we lead through maternity transformation, for example, the Saving Babies' Lives care bundle. The second is that many of our units where we've had difficulties have struggled with 2 things in particular. One, the overall levels of staff they have available to deploy right across maternity pathways, and particularly on delivery suites, where we know we need to get staffing numbers right for the numbers of women that are coming through the services, but also some of our digital systems and how they make, on occasion, things more difficult for our teams rather than facilitating our teams to be able to provide a great service. And the third are failures of board governance and troubles, not just at board level, but then up through the system in terms of genuine insights into what is happening in services. Unfortunately, there isn't 1 or 2 things that you can look at in maternity to know if there's an issue or not. If there were 4 or 5 data points, you could look at those and you'd know, then we would have cracked this a long time ago. It just isn't like that. And so our big focus going forwards is, 1, to have that focus on training, for that training to be really around the team, with no point training people in isolation, because in the small hours of the morning, when we know sometimes we get into difficulties, it's the way that people work and respond together. So having the proper dedicated time for training and leadership training. The second is the work that we've been doing around staffing and digital systems, and Ruth and Simon Eccles are going to talk around those in a moment. Then the third is the launch of a board development programme, which we actually did yesterday, to get particularly our non-executive director champions, but also our executive board safety maternity champions as well, to really understand the questions they need to be asking, the way they need to be engaging inside the maternity services and across the system to get this right. So we think we've got some major successes that we can build on in the maternity transformation programme. What we've now got to do is to make sure that we can get into every single unit in England, and to make sure that the things that we know work are universally applied, so that no woman or family ever gets behind, is ever left behind by anything that we do in maternity. Thank you. And I'm going to hand over to Ruth, who's just going to pick up a couple of those themes.
Sarah Jane, thanks very much for that. I should have introduced you properly at the beginning, actually, but Sarah Jane, well, it says in the paper, but she runs the Women and Children's Hospital in Birmingham and has done a phenomenal job as well, helping out on the testing programme as well recently. So Sarah Jane, it's really good to see you. Sorry, Ruth, over to you.
Thank you. Thank you very much, and thank you to Aidan and Sarah Jane. So let me just first acknowledge Donna Rockerton's first report into the maternity services at Shrewsbury and Telford Trust. It's humbling, it's harrowing findings of the tragic experiences that people received at Shrewsbury and Telford maternity centres. And I recognise the deep and lasting impact on those families who have lost loved ones and those who continue to live with the injury and the trauma that has been caused. So Donna Ockerton set out in her report 7 immediate and essential actions for maternity services across England. This report was published on Thursday the 10th of December, and Manda, myself and Steve wrote out to the service on Monday the 14th of December, asking the trusts to proceed to implement the full set of the 7 Ockerton immediate and essential actions. But we identified 12 urgent clinical priorities, and we did that collectively, myself, Aidan, with Donna Ockerton herself. We asked trusts to confirm their compliance with these immediate actions, to review the report at their next public board meeting, to complete a board assurance tool which included assessment against the NICE guidance relating to maternity, compliance against the CNST safety actions, and a current workforce gap analysis. We received 100% returns from all maternity services on the 15th of February, and we're now reviewing those submissions. As Sarah Jane and Aidan have already said, the themes and the reviews have said we need to look at workforce numbers, culture and leadership, and strengthening the surveillance of our trusts. And so with this in mind, I'm delighted that the board today have agreed in the planning guidance to invest an additional £95.9 million in 21-22 to support the system to address all 7 of those immediate and essential actions consistently. And I'm very pleased that 83.8 million of that will go directly to the system. So it's allocated for the greatest impact on safety. So 46.7 million will go to midwifery workforce, and we will ask all maternity services across England to ensure that they are meeting the birth rate plus requirements, and that's a midwifery workforce assessment tool. It will, I am sure, give us 1,000 more midwifery posts. The second big tranche of money will go to the obstetric workforce, 10.6 million. And there are some actions within the report that have a direct impact on obstetric capacity, fetal wellbeing lead and a consultant ward rounds. We are therefore funding an increase in the consultant time equal to 80 whole-time equivalents in 21-22. And as we've already heard about, the multidisciplinary training is so important. So we're funding £26.5 million in the capacity to release clinicians for training, because I know that has been challenging for organisations to do. We know by investing in workforce capacity to allow teams to train together will improve the way multidisciplinary teams work together. The remainder of the funding will be used to support some national and regional infrastructure, including appoint 2 whole-time equivalent consultant obstetricians in each region and 7 deputy regional chief midwives. It will also include £3 million for an independent senior advocate, as Donna Ockerton has requested. And this will ensure a consistency across England, and that role will be developed and, of course, therefore funded nationally. And finally, we know that we're going to need to build, like we have with international nurse recruitment, a whole programme around international recruitment of midwives, and £5 million will go towards that. The important bit for me around this then is about how we work to make that happen, how we now go and implement this. So we will conclude by working with partners, Health Education England, of course, Wendy Reid, Mark Radford, and making sure that we are able to have that sustainable supply of obstetricians and midwives. Working with our LMS partners, with the Royal College of Obstetricians and Gynecology, and of course with the Royal College of Midwives. So we will work together to ensure that we implement these national recommendations so that we do have the safest care for our maternity care in England. That's all I have to say at the moment, Chair. Happy to take questions, or if we want to just have a tiny bit on digital from Simon first, then I'm happy that too.
Should we just take a small amount of time with Simon on digital, then come back to more broader questions?
Thank you.
Thank you very much, David. The Maternity Digital Transformation Programme aims to give every woman access to their own digital maternity record across the whole of their pathway of care, and to give them control and understanding of the whole of that pathway. We are producing national standards and ensuring adherence to the maternity care data set in order to give the data that Ruth's just outlined we need. We're supporting the business change to ensure that every partner in that pathway of care is accessing the same information, is providing it to the woman, and ensuring that each part of the pathway can see the same information. We've been running 20 small-scale pilots of this programme of work and are now moving to 4 much larger regional models involving millions of patients. The aim being to get to 100% take-up of digital records across the whole pathway of care, ideally by 2024, or we are looking at all possible ways of accelerating the rollout and benefits of the programme. We're looking to produce a market of products that are truly useful to the women they serve, and to improve the information available publicly to women on the NHS website. To that end, we developed the iDecide product to help with the specific recommendation from Donna Ockendon's report to produce much better information. And lastly, we're aiming to ensure that the maternity record forms part of the full life course record and is not seen as an isolated segment, but fits into a full life course record.
Thank you very much, Simon. So look, we've heard from Sarah Jane, Aidan, Simon, and of course Ruth. Have the board got any questions they would like to put to them? I know, David Roberts, you've taken a particular interest in this. Would you like to kick off?
Yeah, thank you, David. And it is one of the most sort of heart-rending and hardest things that we face into, I think. And the thing that I'm curious about, and Sarah Jane, and thank you for the work you've done, but is this issue of leadership and culture, which seems, as we go back over some of the incidents and the tragedies that we've seen over considerable period of time, to be a sort of a common cause, and therefore I'm interested as to how we're going to tackle that, because ultimately this is also about sort of, it's not just tone from the top, it's actions from the top, and therefore it's about, have we got the right people in the right place? Are we confident in the ways of working? And linked to that, have we got the right data, etc. But I'm curious to hear your thoughts on how we're going to try and address the leadership and culture issue, because it strikes me as without addressing that, the rest becomes quite hard.
Ruth, do you want to?
I think the question first was Sarah Jane, and then I'll come in.
Either would be great. Both would be fabulous.
You go first, Sarah Jane.
Thanks for the question, David. It's something that we spend a lot of time debating. I think one of the issues that we can see in the services where things go wrong is that they seem to be operating outside of a line of sight of the board. Often people in the past, I do think this has changed quite dramatically recently, but often in the past maternity services was just sort of left to get on. And often there wasn't particularly visible data, and there just wasn't a general awareness of what good looked like. We weren't always listening to women, I think, too, on some boards, as we should have done. So part of it has been to open that out by having our board level maternity safety champions, and we've had those on the executive side now for several years, and I think that has started to make an impact. We have board teams going to the board so people can make their own assessments about whether they think that progress progress has been made and all of those kind of things. But we've also got some really specific culture tools that we've been using. We did a culture survey in every single maternity unit in the country as part of our maternity and neonatal service improvement programme. That highlighted some themes, and the team worked with every unit in the country to come up with a personal plan to that unit to see what could be done to improve things. But we do come back to this recurrent theme of people having time to lead and time to do the development. And that's, again, why that's an area that's really been prioritised of late. So there's many different things that we're doing, but we can see the tide turning. As I said in my introduction, it really is about making sure that we can reach out to everywhere and make sure that good practice that has worked in most places reaches everybody. And I think the midwifery side has really advanced with having chief midwives in every region and all of those things. That's one of the reasons that Ruth just talked about having a chief obstetrician in every region as well. So we've got people that we can send to go and look and have conversations and see whether they think there are issues, whether we need to give extra training or whether we need to change people around because they're no longer working. So lots and lots of different interventions, but the culture remains our number one thing that we focus on as a transformation programme.
Just to build on that very slightly, agreeing with Sarah Jane. So we know that from all of the research that when people learn together, when people train together, they'll work better together long term. And that's why a significant amount of this investment is to make sure that people are released to go and learn together. And that, I'm sure, will help the culture. Of course, it's all very well, but actually, unless you've got enough midwives and obstetricians, it doesn't help. And that's, again, why a lot of this investment is focused on increasing the numbers of obstetricians and midwives. And I guess what John Rockerton and we are asking boards is to focus on maternity services, to really understand them and to support them and to hear the voice of maternity services. And all of the actions in the 7 actions that Donna outlined are saying just that. And so I am hoping that our boards and challenging our boards to do just that.
Thank you, Ruth. And the statistic that is also truly horrifying is the relative inequality of outcome, which was mentioned. And I don't know, I see Walls put his hand up, maybe, but that's another shocking statistic. And again, it would be interesting to hear how we're seeking to address that.
Well, did you want to come in? Were you coming on a different point?
A different point. I mean, I do agree with David's point. I'd like to hear the answer to that before I come in, if that's all right.
Yeah. Ruth.
I was going to say, Sarah Jane, do you want to do some of the work around continuity of care?
I'm very happy to. I think in the latest Embrace report, we have made a small dent actually, and now I think for black women are 4 times more likely rather than 5 times more likely, which is not amazing, but is a small step. We've done an awful lot of work on this and trying to really work with our teams to make people comfortable with delivering uneven care, i.e. more care to some women than others, to try and level up overall outcomes, which isn't something that's the natural strengths often of clinical teams. So we were very particular over the last year about making sure that women from ethnic minority backgrounds had more face-to-face appointments and had a lower threshold, a lower risk threshold for which we would call them in to escalate care. So we've done quite a few immediate things over the last 12 months that I hope have been impactful. But longer term, we have focused our attentions on continuity of carer. We've talked about this at NHS England, certainly board before. We know the difference that this can make to outcomes for all women. But what we've asked for is for it to be differentially implemented, so that women from minority ethnic backgrounds or from deprived postcodes, where we also have the same issues, have greater access to continuity than white women or those from wealthier areas. And in the last data that we looked at, that was working. We were disproportionately giving continuity to women from minority ethnic backgrounds, and indeed we've got some huge champions of this out in the service. So it will take a little while to see whether that feeds through into the outcome data. But I think as other teams, we're absolutely focused on this and have used the opportunities, albeit it's been devastating because we lost several women in the first wave, but we've used the opportunity of the pandemic to say we need to do things very, very differently now, and I think that has been embraced.
And I'll one final point from me, and then I'll be quiet. But there are also some quite impressive digital tools targeting areas, women from areas of deprivation, women of ethnicity, and again, they can be a powerful community link to support women as well as our own efforts. And I think it's how we link some of those together, I think, is also an important way in which we can help improve outcomes for everyone, but particularly areas where we know we've got work to do. But thank you for the work you've done, and thank you for this. And David, I'm sure it's a subject that we'll come back to regularly.
It certainly is. And well, have you still got a question?
Yeah, that's a great segue into what I was going to just ask about, that last bit of what David, you both said, which is we're going to come back to this. So, I mean, you've given us, all of you, a really good, strong impression of the work you're doing and have done, and that, you know, there's no complacency in this at all, which comes through in spades. I have to say it's one of the most difficult reads I've ever had in this sort of environment. It's just, I find myself a bit sort of, just deeply uncomfortable, let's put it that way. Now, the point about this is that you mentioned culture, and culture is critical, and it's a two-way street. And that's the other way I'm looking. So one is the maternity unit, the other is the board. Sometimes boards, even though you're being transparent and give them information, don't know what to do with it, don't know how to look at it, don't know how to treat it. And so can you just talk a little bit about the support you're giving to help them foster a culture where people want to report stuff that doesn't look very good, and how they then address what they do about it? Because, the danger is if you get that balance wrong, people will quickly shut down and start to sort of, do all the wrong things.
Yeah, thank you. Well, I'll start, and then some of my colleagues may wish to come in. Absolutely. And we have to support boards to do this, because the maternity services, they aren't easy to really get underneath. So one of the things we've been doing since 2018 is to have a maternity support programme, where we have been able to support going into boards, having that conversations with boards directly before going into the maternity units themselves. Since 2020, we've strengthened that so that we're now looking not at supporting those units just when they've flagged with the CQC, but those are the ones that are struggling. And that's where we're at now, and that's the most important that we're doing. We do know that we're having to work through boards, but with our consultant obstetricians and midwifery and our midwives, and having our support people going in. We've had some really good feedback from boards, and it's been really interesting feedback too from the staff, that they've seen boards listening more and understanding more after they've been part of the support programme. I wonder whether any of my other colleagues wish to comment.
So if I can come in there, Ruth, well, I think this is a really important point, and there's lots of complexity to it. But one of the things very striking is there is an element of isolation in some of these units, that they are not sharing practice across them, and we are trying to make sure that that doesn't occur. And certainly in Shrewsbury and Telford, their practice was quite separate, if you like, from the rest of the world. And we often refer to remote and rural. They're not always remote or rural, but they are isolated in some sense from the rest of the system. Recently, two of the patient safety team went on an investigation training programme. These things exist, and this was run by a charity, Baby Lifeline. And there were Shrewsbury and Telford staff on it, and they were very, very struck. The staff became really quite emotional when they realised how wrong they'd been doing the investigations and the impact that it had, and they had no understanding. They just simply hadn't understood how to do it properly. So I think, there have been huge strides in maternity. The normal distribution has moved in the right direction, but there has been a bit of a tail. And I think the maternity support programme has been really important in bringing that tail up to the levels we expect of others, but also in challenging this isolation and looking at things like the maternity learning support networks and making sure that there is a mix of providers in those, so that there are strong providers to support those with challenges, and that sharing and collaboration of learning that needs to occur.
David, just one final point to add. From the session that we did yesterday with all the board safety champions, we had women with us who told really powerful stories. We can do all the things, we can write all the things down and look at all the numbers, but we have to show we care. Because when our non-executive director and our board colleagues can go out into services, can speak with women and show them that they care and show them that they have the passion for the services, that's when they open up and start sharing, and that's when we've got the ability to do the transformation. If things are seen as a back and forth, what's this data say, what's this, what's that, that's when people clam up. And we had a long discussion about the care and compassion. That's what we're asking for from our staff. What we think is safe and what women think is safe clearly are very, very different things. They need to feel psychologically safe as well as physically safe. We have to embed that culture, and I think that threads through not just maternity but everything that we do, and that's another theme really of the leadership development work that we're doing. We want to work with people who are passionate about maternity services. This isn't a box to tick. This is the start of the next generation, and if we are ever going to break into health inequalities, we have to start in maternity services. If we don't get it right in maternity, none of our other services really stand a very good chance. So we have to get a lot more passionate. Anything that the NHS England and improvement boards can do to support the maternity transformation board to transmit that passion on would be always gratefully received.
Well, Sarah Jane, I'm going to come to Simon in just a minute, but I remember, David Bean will remember this, when we both went up to Morecambe Bay to meet James Titcombe and some of the others who'd lost their children in Morecambe Bay. It is a very, very profound and moving experience to meet mothers who've lost their babies or husbands who've lost their wives. So I think Sarah Jane, perhaps we might arrange a visit and come and sort of see you in Birmingham at your hospital, and maybe go to Shrewsbury, or well, anyway, you could maybe Ruth and Sarah Jane, you could put your heads together, because I think it is, like Wal says, it does leave one feeling very sort of uneasy. So Simon, you're going to finish, I think.
Yes, thank you, David, and thank you, everybody. I think this has been a very powerful discussion. I think it's worth drawing out the distinction which has been implicit in this conversation between the majority of maternity services which are good and improving, and Sarah Jane set out some of the data to underpin that assertion, versus, as Aidan has just pointed out, those smaller number of units that are isolated, the tale of concern, where frankly we see unacceptable practice. And we can call it culture, you can describe it as isolation, but the fact is that we've seen through Morecambe Bay, we've seen through East Kent, we've seen through Shrewsbury and Telford, sometimes unacceptable standoffs really between different groups of midwives and obstetricians, and we've just got to, I think, call it as it is and say that is not good enough, and we will not put up with that any more. So I would suggest a couple of next steps on the back of the discussion we've just had. The first is, I think it would be very good for the boards to hear from Bill Kirkup at some point over the next 6 months as to where his work has got to. I commissioned him to do an external review of services in East Kent in the same way that Donna Ockenden has been doing in Shrewsbury and Telford. And secondly, I think on the broader change programme, the £96 million that we are allocating today will drive a lot of positive change across maternity services, but we should be under no illusion that that will be mission accomplished. I think this is the first 96 million. We will need subsequent tranches of additional funding to do the job that needs doing in maternity services across the NHS.
Thanks very much for that, Simon. So Ruth, thank you very much. Sarah Jane, Aidan, Simon Eccles, thank you all very much for coming today. And we'll definitely be in touch again for a follow-up meeting soon. I think getting Bill Kirkup along will be great. He did the Morecambe Bay review as well, of course. So thank you very much, Ruth. Right, I think that is the last item on the agenda. There are a few other papers that are there for noting. Does anyone on the board have any issue, any other business they'd like to raise, or can we conclude the meeting? Excellent. Thank you all very much. Thank you.